Bismillahirrahmanirrahim. Welcome you all to today's workshop, virtual workshop on gynae oncology. So today we are going to start a workshop on cervical cancer. But what we have decided that our topics will be not a really book teaching topics, but we will be talking with the real life challenges. So virtual workshop is on cervical cancer, combating the real life challenges. I am Dr. F.M. Kamaluddin. I am the Scientific Secretary of Oncology Club, who is the organizer of today's program. I want to start with a small introduction of our organization, Oncology Club. Oncology Club was founded by this great man with a great vision, Professor A.B.M.F. Karim, who was a emeritus professor in Free University, Amsterdam, but a man of Bangladesh. And in 1996, he started the club named Oncology Club because he realized in our culture, senior and junior.
All your slides are not visible.
Sorry?
Your slides are not visible.
Slides?
Okay.
You're not sharing the slides, yeah.
So it's okay, sir?
Yeah, now it's okay.
Okay, sorry. So the Oncology was founded by this great visionary man, Professor A.B.M.F. Karim, who was emeritus professor in Free University, Amsterdam, but a man of this soil. In 1996, he formed Oncology Club because he realized, like the Western country, in our region, seniors and juniors don't talk easily. There is a big barrier which can act as a barrier for sharing of knowledge. For the proper flow of communication between seniors and juniors, he created this organization and named it as a club where all can come and chat. In 2001, he created a big event, and there around 500 doctors joined from local and also from SAARC countries. Many of them were his old students. And there he proposed to form SAARC Federation of Oncology, the first platform of oncologists among SAARC countries. With that initiative, Bangladesh became the proud founder of SFO, the SAARC Federation of Oncology, like the proud founder of SAARC. And thereafter, meeting has been rotating from all the member countries, and initially every 2 yearly, then every yearly. In 2007, a socio-scientific conference was organized, and in that meeting, many foreign dignitaries joined us, and we found a great friend, K Goodman, and she has transferred from Boston to Dhaka, and till now we are getting her support. We believe that Oncology Club made a great discovery of this good friend from Boston. Oncology Club also sent overseas people to overseas training, and in 2009, among 14 candidates, Oncology Club sent 2 faculties of gynae oncology to USA, to the center of Goodman, and they were trained there for around 3 months. And both of them are now the leading gynae oncologists in our country, most promising, I would rather say, Professor Jannatul Firdaus in BSMMU and Professor Shahana Parveen in NICRH. In 2008, the first vaccination program against cervical cancer was also initiated by Oncology Club. And you can see Professor Sabera Khatun, Samina Chaudhary, and Professor Fauzia, all the common face of gynae oncology are there, who were the part of that historical moment. And our founder was giving the lecture, and it was supported by Grameenphone. Professor Karim was always a believer of trained manpower. As a result, we created a partnership with IAEA and arranged 20 programs for oncologists, physicists, and radiation therapy technologists. And we have been collaborating with different organizations like IAEA, UICC, ISMO, ISTRO, and also the founder of SFO. From 2014, every year, Oncology Club is arranging the largest multidisciplinary meeting on oncology in our country, named Bangladesh International Cancer Congress, where gynae oncology is treated as one of the most important components. In 2016, Oncology Club hosted the yearly conference of FNCA. Beside this, every year Oncology Club used to organize workshop on gynae-oncology. You can see the known face of this region and overseas joined the program as our faculty. In the COVID era where social distancing became an issue, we wanted to connect each other through virtual platform. So we started virtual academic program. Till now, near about 60 program has been done, among where 26 is from gynecological oncology. Beside this weekly program, we have also arranged different virtual conferences, where gynae-oncology conference was there. And recently we had running the SARC Radiation Oncology Symposium and planning competition. During this period, we run for gynae-oncology, run the academic session, but also some tumor board, virtual tumor board, where we used to connect with our different medical colleges, like from north, Rajshahi, Rangpur, Dinajpur, Bogura, then coming down to Mymensingh, then to the east, upper part, north is Sylhet, then came to Dhaka, Kumilla, and Chittagong, Faridpur. So all these we have covered, and with all the medical colleges, we have arranged tumor board. And as a result, this center were exposed to many foreign faculties, and there we have discussed their challenges, what they face in their sometimes resource limited situation. And these are we have 16 to 17 foreign faculties who enlightened us in this tumor board. And today this program is designed to make a summary of that continuous endeavor, where we have selected 6 medical colleges who will be giving presenting their case, and it will be discussed with our faculty that how can we make a way out. And also there will be tumor board. Today the Oncology Club is running under the leadership of Professor M.A. Hai and the Secretary Professor A.M.M. Shariful Alam. And we are blessed to have the leadership of these 2 great souls. And we are going to continuing our journey with the support of all our faculties. So thank you very much. That was my presentation. Now I want to request our President, Professor M.A. Hai sir, as our custom, to say a few words and start the program. So Professor M.A. Hai sir.
Thank you, Kamal. Bismillahirrahmanirrahim. On behalf of Oncology Club and myself, I offer you the heartiest welcome and thanks for joining in our call, organizing this gynae-oncology program, the gynae-oncology service in Bangladesh. The motto of as you have heard from Kamal, that our motto of the Oncology Club is to improve the oncological services in this country and also in the SAARC countries as well. And with that goal in our mind, we are organizing this conferences and seminars continuously throughout the year. And now this we have already made some developments in gynae-oncology, particularly in lots of. Every week we are organizing this. Today we have developed another new chapter of organizing a workshop. Problems we are facing day to day, as already Kamal said. So without any delay, I want to go to immediately to start the function. Kamal started immediately.
Thank you, sir. So today the program is for 3 hours, and there will be 2 parts. First part, we will be discussing our 6 challenging scenarios, and the second part will be a tumor board. Professor Shahana Parveen, who is not only a promising gynae-oncologist in our country, but also the person who has been running this show for last so many months. And she is the individual who is carrying the program every week, alternatively running an academic program and tumor board. And her relentless effort made it possible to carry the program till now. And till now, she could engage around 30 plus foreign faculties in our regular program. So now I would request Professor Shahana to take over, because she will be the coordinator of this program and she will moderate the whole session. Shahana, would you like to take over and start your program? Over to you, Professor Shahana.
Thank you very much. Thank you, Dr. Kamal Bhai. Assalamu alaikum and very good evening. Welcome you all to this workshop, the cervical cancer combating the real life challenges. We have two sessions of this workshop. The first session is the real life scenario. The scenarios which will be discussed today's session, those are our medical college colleagues are they facing their day-to-day life practice. And the moderator of this first session is Professor Dr. Amita Maheshwari, and the second part of the session is the tumor board, and the tumor board will be moderating by Dr. Rupinder Sekhon. And two cases will be discussed in the tumor board. One is advanced stage carcinoma service and another is the early stage carcinoma service. We are always grateful to the medical colleges, though we could not add all the medical colleges among the 10 medical colleges who are with us in last 7 months. We have included only the 6 medical colleges, and also grateful to all the gynecology and other oncology colleagues, and especially we are grateful to the AGOI. With support, we couldn't complete these programs, and we can do this program, and also Dr. K Goodman and Santosh. The faculties of today's program are Shorna, please. Shorna.
I have already shared the program agenda of faculties.
Faculties.
Yes, ma'am.
The faculties of just a minute. Yeah, you please join. Please join. Yeah. Yes. The faculties of today's program are Dr. Bhagyalaxhmi Nayak. Dr. Bhagyalaxhmi Nayak is Associate Professor of Gynae Oncology, Acharya Cancer, Cuttack, India. Dr. Professor Amita Maheshwari. Amita Maheshwari is head on the Department of Gynae Oncology, Tata Memorial Hospital, and she is also the President-elect in Association of Gynecological Oncologists of the India. Dr. Bhavana Rai. Dr. Bhavana Rai is the Professor, Department of Radiotherapy, Postgraduate Institute of Medical Education and Research, Chandigarh, India. Dr. Peedicyil. Sir is the former professor and head on the Department of Gynae Oncology, Christian Medical College and Hospital. Now she is working in Comprehensive Cancer Center in Muscat. And Dr. Annie Catherine Goodman. Annie Catherine Goodman is gynae oncologist and the professor of obstetrics and gynecology and reproductive biology, Harvard Medical School, Boston, USA. And Dr. Rupinder Sekhon. Dr. Rupinder Sekhon, ma'am, she is the senior oncology at Rajiv Gandhi Cancer Institute and Research Center, New Delhi, India. She is also the Secretary General of Gynae Oncologist of the India. Dr. Santosh Menon. She is the professor and the pathologist of GI and gynecological oncology in Tata Memorial Hospital, Mumbai. Next. Shorna.
Next.
These are the Professor Dr. Sabera Khatun. Sabera Khatun, madam, she is the ex-professor and head Department of Gynae Oncology, Bangabandhu Sheikh Mujib Medical University. Dr. Shirin Akhtar Begum, she is Professor Gynae Oncology, Bangabandhu Sheikh Mujib Medical University. Dr. Rupinder Anwar, she is Professor and head Department of Gynae Oncology, National Institute of Cancer Research and Hospital. And Dr. Jannatul, she is Professor of Gynae Oncology, Bangabandhu Sheikh Mujib Medical University. Next. And the presenting medical colleges today, and Dr. Shoela Shahana is Assistant Professor in Chittagong Medical College Hospital, and Dr. Taslima Nigar-Gynae, she is Assistant Professor, Obstetrics and Gynae, Maheshwari Medical College Hospital. Dr. Zubaida Gulshan Ara-Sweety, she is Junior Consultant of Hossain Gynae, Abdul Rahim Medical College and Hospital. Dr. Ishaq Jahan Koki, MAG Osmani Medical. Dr. Shopna Bish, Senior Consultant of Gynae and Ops, Faridpur Medical College, and Dr. Mahbooba Khatun, Assistant Professor, Rangpur Medical College. And the evidence-based presenters of this 2 days workshop are the Dr. Taslima Nigar, Dr. Rifat Ara, Dr. Yaasmin, Dr. Rumana Afroz, and Dr. Sabiha Yeasmin, and also the Dr. Nusrat Hoque. Now I request our moderator of this first session, Professor Dr. Amita Maheshwari ma'am, to conduct the session, first session. Amita Maheshwari ma'am, please.
Hannah, you call the speaker, then she will call the presenter. First case. First case
will be presented by Dr. Shoela Shahnaz. Shoela Shahnaz, she is Assistant Professor in Chittagong Medical College. You please present your case.
Give the title of the scenario, Shahana.
The title of the scenario is the histopathology report with inadequate specimen.
Sohela, please start.
Thank you, madam. Assalamu alaikum. Next slide, please. A 45 years old lady referred from oncology department for gynecological evaluation with the diagnosis of carcinoma cervix after hysterectomy. Her history was she was a normally menstruating woman with mother of 4 children, all delivered vaginally, and she had been on oral contraceptive pills for the last 10 years. She presented with 2 episodes of postcoital bleeding. From prescription, we found that her uterus was bulky, cervix broad, and fornices were free. Investigation revealed pap smear, high-grade squamous interepithelial lesion, colposcopic guided biopsy showed cervical interepithelial lesion, neoplasia, grade 2, and ultrasonography of whole abdomen was normal. Considering all these, she underwent total abdominal hysterectomy with bilateral salpingo-oophorectomy in a clinic at Satkania Upozela, Chattogram. Poroperative findings was not written in her discharge paper. Histopathology report revealed macroscopically 3 small pieces of cervical tissue, largest one measuring 2 × 1 centimeter. Microscopically, it was a small cell, a squamous cell carcinoma, moderately differentiated, but there was no comment on limb vascular space invasion and depth of the invasion. On general examination, nothing abnormality was detected. Her wound was healthy and vault was healthy too. We tried to communicate with the clinic, but the clinic could not provide the whole specimen, and only the cervix was sent for histopathology because the patient was not able to bear the expenses of the whole specimen for histopathology examination. And with this limited pathological information, she was referred to oncology department. Thank you.
Come on, next presentation. I'm going to stop share. Next presentation. Shahana.
Yeah, so very
Next
good evening, Amita here. So may I invite Dr. Taslima Nigar to present evidence pertaining to the case presented just now. So Dr. Taslima.
Thank you, madam. Assalamu alaikum. Now is the time for evidence-based discussion regarding the histopathology report with inadequate specimen. Pathology of cervical carcinoma books, chapter 6 provide the accuracy of histology interpretation and diagnosis is strongly governed by the quality of tissue provided, proper handling and processing of the specimen. Next. The single most common cause of an inadequate biopsy specimen is failure to provide sufficient amount and depth of abnormal tissue. Unless the specimen includes the base of the tumor and its underlying stroma, a current diagnosis may not be possible. Next. ESGO and European Society of Pathology in their cervical cancer guidelines give some principles and guidelines how properly a surgical pathology we should handle. Next. The principles are The pathology represents a key component in the management of cervical cancer patients, and the report should be comprehensive of all the features which allow a cervical carcinoma patient to be placed into a risk group, which ensure the appropriate management. For substaging of tumors, accurate tumor measurement is also very important. The presence and absence of limb vascular space invasion, involvement of extracervical tissue, and the margin status is also critical for patient management. Next. 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 They give some guidelines how the specimen submitted to the pathology for evaluation. Patient information, previous cervical cytology, histopathological specimens, clinical and radiological data, colposcopy findings should be informed into the requisition form. And details of surgical specimen need to be itemized in the specimen. Whether the tissue is taken from cone or loop specimen, trachelectomy, type of hysterectomy, presence of ovaries and fallopian tubes, presence of lymph nodes and designation of the lymph node sites, presence of vaginal cuff, and presence of paramecia. The specimen should be sent to the pathology department in a container with liquid fixation. Next. When cervical cancer has diagnosed, its adjuvant treatment and prognosis depends on some risk factors. The National Comprehensive Cancer Network highlights the risk factors of the cervical cancer. Next. 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 The risk factor regarding the uterus, previous one. The risk factors regarding the uterus are next. The risk factors regarding the uterus are the types of hysterectomy, site, grade, stromal invasion, surgical resection margin, and limb vascular space invasion. Other tissue involvements like parametrium, vaginal cuff, fallopian, ovaries, and peritoneum. And the most important is lymph node. Next. Now the question is how we cut the cervical tissue Nevena Sen et al. And their colleagues that block all cervical tissue is done.
Dr. Priyanka Bhakat, please mute your microphone.
The whole lesion has been processed, exclude an invasive component, and allow assessment of the inferior excisional margin. Next. The appropriateness of examining the entire cervix histologically in hysterectomy specimen from women with a previous history of cervical intraepithelial neoplasia or dyskaryosis. The paper was published in the Journal of Clinical Pathology in 2001. Next. The aim of the study was to investigate the necessity of examining the entire cervix after hysterectomy specimen from women with a previous history of cervical intraepithelial neoplasia or dyskaryosis. They conducted the study into 71 patients, and each of the cervix was blocked up to 26 times. Next. And they found that among 21 patients without having prior histological confirmation of the presence and grade of the lesion, 8 patients had cervical cancer. And among the 20 patients having positive smear or biopsy, between the initial diagnosis and the hysterectomy, carcinoma cervix was found in 3 patients. Next. The result supports the continued practice of examining the entire cervix in hysterectomy specimen in women with a previous cervical abnormality, regardless of its histology or cytological grade, in the presence of interim positive smears or biopsies, and if such surveillance is not available. Next. So the take-home message is an inadequate biopsy specimen may not contain the cellular component and result will be misdiagnosed. So we should continue practice of examining the entire cervix in hysterectomy specimen. Next, and thank you very much for patient hearing.
So thank you, Dr. Shaita and Taslima for presentations. So I think you have presented a very interesting and very relevant case. Now, I would say there are two issues. One is scientific, why the a detailed histopathology should be done, and the second is economics or finance. So let's start with the first point. Let me ask AK Goodman. Are you there, AK? Hello. Hello.
Iki, are you there?
I think she's not there. Okay, let me come to Dr. Rupinder. Is she there? Could she join? Okay, Dr. Abraham.
Yeah, I'm there.
Okay. So there is some lag, I think.
Rupinder is there.
Okay. Okay. So the question is, can you just summarize why it is important to have a detailed histopathology, and then I'll request Dr. Santosh to tell what are the important features a pathologist should report in a specimen of cervical cancer.
Okay, so if I were to summarize, just let me see if you can see me. Actually, I've got.
Yeah, we can see you, yes.
Okay, I've just rushed home. So if I'm looking like something the cat has brought in, you'll have to excuse me. So I've just reached home. Okay. So see, the complete cervical specimen is very important because you need to know about the ectocervix. More importantly, you need to know about the endocervix. And only if you have a complete cervical specimen can the pathologist take adequate cuts to be able to actually tell you what the lesion is all about.
Right. So I think what, we are trying to say that the entire specimen, it's just not the cervix, uterus and adnexa and vagina, whatever.
So I just said about the cervix, that's what I'm saying. Yes, okay, of course, sure. You should have the uterus and you should have both the tubes. And if relevant, you need to have the ovaries as well. But if we are talking specifically about cervical cancer, it is very important to have the whole uterus, to have the parametrium, the nodes, the tubes, and so on and so forth. There's one thing, what we used to previously do, we used to cut open the specimen of ourselves and then send it to the pathologist. So to be able to see what the gross is and decide a few things on that, especially for the CA endometrium. But now our pathologists do not want that, and they want to dissect the specimen themselves. So we are not doing it any longer. I do know Amita, the practice followed at TMH.
Yeah, so I think in this patient, the cervix was only cut in 3 pieces, whatever tumor, and then sent, only 3 pieces were sent. So Santosh, as a pathologist, if you get those 3 pieces, how would you interpret and what will be your, your reaction, and how will you report on that histology?
Yeah, somebody just, good evening, everyone. Good evening, Dr. Kamal and Dr. Shahana, and thank you for having me here. Dr. Amita and Dr. Rupinder, I would be very surprised if I got only 3 bits from a hysterectomy and TH BSO specimen from the cervix. And it would be surprising, but the point is, it would be difficult to orient just 3 bits of cervix. So if I were to speak of this particular patient in which the cytology was reported as HSIL, and the cervix biopsy was called as SIN2. So if a patient has a biopsy diagnosis of SIN2 and there is no gross lesion on the cervix, supposing there was no gross lesion on the cervix, then the optimal thing or the necessary thing is to submit the entire cervix as a cone. So you would take approximately 20 to 35 sections of the cervix from clock position 12 to again clock position 12, complete clock position, so that we in the entirety see the cervix, so as to pick up the microinvasive or the stage 1A1 or 1A2 cervix cancer, because staging is important. This would be whereas if the clinician has clearly seen a gross tumor of say size 2 centimeter, 4 centimeter, then probably we are dealing with a 1B tumor, and that would be a different scenario where we would take 3-4 sections. So coming to the point that when we have 3 sections sent from the pathology lab for examination, we would try to do our best, and we would try to see what is the grade of the tumor, because in a poorly differentiated cancer, the likely possibility of tumor invading deep into the cervical stroma is more, even though it is not oriented well. So certain subtle features, LVSI is important. LVSI, depth of invasion, these are very important for adjuvant radiation determination of the patient. So that are the basic things which we would follow. Obviously, if we don't have the size of the tumor, the initial A1 and A2 and B staging would be difficult in such cases.
So, Dr. Santosh says you have to take 20 to 30 sections. My question to Dr. Kamaluddin is, here optimum versus resources. So how do we optimize? Apparently, only 3 bits of cervix was sent because of financial reasons. It's not that the person was not aware, but just because of finances. So the question is, how do we optimize, or how do we, balance the two?
So I think there is finance and also some communication issue, because somebody may think that if malignancy is diagnosed, that is fine. So we need to orient to our all the colleagues that only malignancy is not enough. We need to know all the details to take about the decision. So as you see, the main issue was to send the whole specimen, take a charges. So the clinic at the very remote area, they want to make it very economical. To save the money, they take out only the part of the representative tissue and send it at a cheaper cost. So it isn't a very big money. It is also the cost and also the, the orientation. Once we can educate that, well, we need to have all the total specimen and all these things, maybe we can overcome these also.
I guess the difference is not huge, sending the entire specimen versus few pieces. Is it that, maybe people are unaware, they think only small bits will suffice, or is it,
As I said, this is 2 issues. One, they think that, once we can show that it is malignant, that is fair. So they are not bothered about these things. Another is, yes, there is a small amount of money issue, but we can overcome it if we can really convince that there is the importance of getting all the details.
I think, Dr. Kamal, the easiest thing to do is, especially, so this was a clear-cut cancer, probably a large, huge growth, which was seen in the cervix. So taking 2-3 sections from that, especially from the greatest depth of invasion, would probably suffice. The issue comes when there is no gross lesion and we are dealing with a SIN 2, SIN 3 case, and we are really trying to get a case which is A1 or A2, 1A1 or 1A2 tumor. So that time you would have to take more and more sections and probably process the entire cervix as a cone. Factor is not wouldn't change much in these things. The best part is for the pathologist to follow CAP guidelines or RC path guidelines. They are freely available on the internet, freely available on all these websites, and they can use these synoptic reports to use. Even in Bangladesh, people can very easily use them. They're freely available on the internet.
Yeah, that's quite right. But
Can I have some comment?
Yes, madam.
Sabera Khatun.
Yes, madam, please go
ahead. This is not the question of pathologist. This is the question of gynecologist, I think, because CIN2 case should have a lip biopsy before going for hysterectomy. This is the first thing should follow by the gynecologist, because CIN2 case colposcopically, here the question of the expertness of the colposcopist, it is one of the important question. Next question is, if it is CIN-HCIL and CIN2, then it should be first done, the invasiveness should be first excluded by doing lip biopsy. And if the patient would have the lip biopsy, then the squamous cell carcinoma, invasive squamous cell carcinoma could be diagnosed earlier. Then the patient could be managed accordingly. I think the initial management, there is a big gap in the initial management, because the lip biopsy specimen lip biopsy from the lip biopsy specimen, invasive cancer is very unlikely to miss the invasive cancer in a lip biopsy specimen. So it is the gynecologist who should be very careful before doing.
Right. So it's a gynecologist only because cervix is, what is the, there is cervix. Okay. So I think what we are trying to say that right from initial workup, a proper colposcopic examination, a biopsy if it shows high grade lesion, a leap excision biopsy to rule out invasive cancer, especially if it is a SIN3 lesion, you need to rule out invasive cancer. And the other point we want to highlight from this case is it is extremely important to send the entire specimen intact without distorting it, including cervix, uterus, vagina, adnexa. Everything should be sent together. Pathologists need to do a detailed gross examination. Grossing is extremely important in a case of cancer. And also for microscopic examination, the entire specimen should be sent because adjuvant treatment, stage, patient's prognosis, it depends on histopathology. So if we do not provide adequate specimen to pathologists, they won't be able to give us a proper report, which in turn will lead to inadequate or inappropriate treatment for the patient and leading to inferior outcome. I think this is the message from this case. Should we move on to the next in the interest of time?
Yes.
Amita, can I add one thing only?
Yeah. Sorry, Bhavana.
Just a reminder that there is no disease in the uterus that tells us that there is no underlying cancer cervix, like myoma, AUB, so many other things are there, because many times we see patients operated for myoma, but the biopsy later comes as a myoma with CS cervix. So
absolutely,
I think
yes, very important point, Bhagya, you made. We do get patients where surgery was done for DUB, so-called DUB, and it eventually turns out to be cervical cancer. Move on to the next case, please.
Yes. Now our next presenter is Dr. Kausar Nigar. She's from Maheshwari Medical College Hospital, Kausar. I request for Dr. Kausar Nigar to present her case. Dr. Kausar Nigar, please.
Thank you, madam. Please share the slide, please.
And she will present on the case is the incidental diagnosis of carcinoma cervix after simple hysterectomy, whether completion surgery or non-surgical treatment. Yes, Kausar Nigar. Next slide, next.
Next. Mrs. X, aged 45 years, regularly menstruating lady, para 2, living 2, wife of a farmer, presented at Haluagat Health Complex, Mymensingh, with the complaints of menorrhagia for 5 months, postcoital bleeding for 2 months. She is non-diabetic, normotensive. Age at her marriage is 15 years. She delivered first baby pervaginally at the age of 16 years. She used to take combined oral contraceptive pill for more than 10 years. Her husband is a smoker. She gave no history of cancer. All her vitals were normal. At that time, pelvic examination revealed firm, expanded, irregular cervix, bleeds on touch, but no obvious growth was there. Uterus was bulky and normal. Adnexa were normal. Ultrasonogram revealed bulky uterus and broad cervix. She was diagnosed clinically as fibroid uterus, and total abdominal hysterectomy with bilateral salpingo-oophorectomy was done at Upazila level in a private clinic. Then cut section of the cervix was suspicious, so uterus and adnexa were sent for histopathology. Histopathology report revealed uterine cavity is irregular, myometrium is partly thickened, both ovaries and fallopian tubes unremarkable. Microscopic features shows cervix shows invasive squamous cell carcinoma moderately differentiated with extension to uterine wall. Lymphovascular space invasion was present. Margin status negative, stromal invasion present. So it is diagnosed as a case of incidental finding of invasive cervical cancer after simple hysterectomy. Then the patient was referred to our hospital, that is Mymensingh Medical College Hospital, for further management. Evaluation was done clinically and by imaging. And after proper evaluation, there was no pelvic growth, or the pelvic examination revealed normal findings, and we consulted with our oncology colleagues, and pelvic MRI could not detect any parametrial involvement, and lymph node were negative. So tumor board decided for completion of surgery followed by adjuvant treatment according to the final histopathological report. Thank you.
Thank you, Dr. Kausar Nigar. Now I request Dr. Rifat Ara. She is from National Institute of Cancer Research and Hospital to present her evidences. Dr. Rifat Ara, please.
Assalamu alaikum. Heartiest welcome to all to my presentation on evidence-based guideline. This is a publication by J.Y. Park et al. From Annals of Oncology Journal, which compared completion surgery and non-surgical treatment in occult invasive cervical cancer among 147 cases. After median follow-up of 10 years, recurrence rate were please previous slide. Okay. After median follow-up of 10 years, recurrence rate were similar in both surgery and radiotherapy group, but complications were lower in surgery arm. The authors concluded radical parametrectomy as a preferred treatment option. Next slide. To find out the answer to the question, what is the best treatment option in occult invasive cervical cancer after simple hysterectomy, F. Nardusi et al. Published a retrospective analysis from 10 years record. Overall survival and disease-free survival were significantly better in surgery arm with minimally invasive surgery compared to radiotherapy or concurrent chemoradiation group. Next slide. A multicenter retrospective study of 89 cases by Huimin Bei et al. Published in BMC Cancer Journal found that 5-year overall survival and recurrence-free survival were significantly better in occult invasive cervical cancer if tumor size is less than 2 cm with superficial stromal invasion, negative margin, and no lymph node metastasis. Next slide, please. Recent NCCN guideline recommends only surveillance for stage 1A1 cases with no lymphovascular space invasion after histopathological review. For stage 1A1 with lymphovascular space invasion, 1A2, 1B, and those with positive margin or gross residual disease, thorough evaluation is recommended by history, examination, investigation, and advanced imaging. Next slide, please. Occult invasive cervical cancer with negative margin and negative imaging findings have 2 treatment options: radiotherapy with or without chemotherapy or completion surgery. Please, previous slide. Please come to my slide. This one, please. Okay. Radiotherapy with or without chemotherapy or completion surgery. Completion surgery is recommended if set this criteria is not met on hysterectomy specimen, which includes information about tumor size, stromal invasion, and lymphovascular space invasion. Completion surgery comprises total parametrectomy, upper vaginectomy, pelvic lymphadenectomy with or without para-aortic lymphadenectomy. Para-aortic lymphadenectomy is category 2B recommendation. After surgery, if lymph nodes are negative and no residual disease, observation is recommended. But If lymph nodes are positive or surgical margin positive or parametrium positive, category 1 recommendation is adjuvant concurrent chemoradiation. Brachytherapy is individualized for positive basilar margin. Next slide. Primary concurrent chemoradiation is category 1 treatment in occult invasive cervical cancer for cases with positive margin, gross residual disease, positive imaging, or tumors. Those meet this criteria. Next slide. ESGO, ESTRO, and ESP guidelines are based on expert pathology review and multidisciplinary tumor board. Optimal imaging is needed. Aim is to avoid dual modalities of treatment. Similar to NCCN guidelines, no additional treatment is needed in stage 1A cases with negative lymphovascular space invasion and negative surgical margin. Next slide. Radiotherapy only is recommended in stage 1A2 with lymphovascular space invasion. Please mute. Keep mute, please.
Keep mute.
Okay. Radiotherapy only is recommended in stage 1A2 with LVSI 1B and 2A less than 4 centimeter if no residual tumor is found on imaging. Primary concurrent chemoradiation is the treatment of choice for residual tumor on imaging advanced stages with positive surgical margin and positive lymph nodes. Radical compression surgery is recommended for negative lymph node cases on imaging and if there is no upfront indication for adjuvant surgery. Next slide, please. Next slide. Next slide. Previous slide. ASTRO guideline is not defined from the above mentioned guidelines. Completion surgery is preferred option. Radiotherapy or concurrent chemoradiation is recommended if surgery is technically difficult or if hysterectomy specimen and imaging reveal risk factors for adjuvant radiotherapy or concurrent chemoradiation. Next. Thank you everyone for giving attention to hear me.
Okay, thank you. So here I think we will discuss 2 points in this case. One is how to prevent or avoid such unpleasant scenario. So Bhagya, how to avoid such situation of getting post-operative surprise diagnosis of cervical cancer?
Yeah, going back to the case, I think there was enough evidence that we are going it's not a simple hysterectomy. There was a growth in the cervix, which was thought to be a myoma, I think. So this is a very common mistake that we see in our day-to-day practice, that many times the ultrasonologist has suggested a biopsy, but the gynecologist has gone ahead and done a hysterectomy and assuming it to be a myoma. So I think this is the biggest mistake that we do. And I'll reiterate what I've already told, that no AUB, no prolapse, no myoma contraindicates the coexistence of a cancer cervix. So I think all the cases before operating should be seen clinically properly. The cervix should be examined properly and a pap smear taken, and that to visualize with a good light, because many times also small lesions may be missed. So I think we have to take all the precautions, because in countries especially where the cervical cancer incidence is quite, I think we all have to be very careful when operating, especially when we don't have any screening or vaccination in place.
Absolutely. So I think very clear message. A thorough evaluation is absolutely mandatory before subjecting patient to a hysterectomy for DUB or for fibroid, because in this patient there were enough indications to their cervical evaluation was in fact required. She had unhealthy looking cervix which bled on touch. I think someone must just thought of a chronic cervicitis kind of situation. So least we have to do a good examination with bright light, and if possible use acetic acid. So VIA, if don't have facilities for cytology. The next question is to Dr. Ibrahim. Now, how to manage these patients? Of course, guidelines have already been given to us, but coming to this patient, what you would have done in this case? So a lady who had cervical lesion which was invading stroma, LVI positive. I think uterus was also involved, although we didn't know exact T size. We don't know.
I think, yeah, I mean, the approach is that first of all, review the operative findings, detailed pathology review, speak to the doctor concerned, pathologist concerned, and if there is anything to suggest that adjuvant radiation would be required, then we should go for radiation, chemoradiation rather than surgery. Like in this particular patient, when there's extension, quite a large growth extending into the uterus with the stromal invasion, I think she would definitely need radiation. So I would not have chosen parametrectomy. And like Dr. Ara said, if it is likely to be 1A and then you can do without, that's fine. But parametrectomy may be difficult, especially if it's depending on the duration after the initial surgery. There will be additions, there will be those sort of practical problems, plus scheduling for your surgery also may take time. It may not be possible to do it straight away. So these practical considerations are there, but I think the most important thing is whether she would require radiation post parametrectomy. So in this particular patient, definitely I would have sent her for chemoradiation.
Dr. Rupinder? Is she there, Rupinder? Dr. Goodman, is she joined?
Can you hear me?
Yeah, hi, you are.
Oh, actually, my laptop packed up and so I've just come on the phone. See, I agree with Ibrahim completely. I too would send this patient straight away for a chemoradiation. She's got gross disease as it is, and I think it is just a euphemism trying to do parametrectomy patient. All of that.
Yeah, I mean, message দিয়েছি স্যার ডিসকাউন্টের পর প্রোডাক্টের প্রাইস গুলো কি দাঁড়াইছে এটাকে মানে ডিসকাউন্টের পর কোন প্রোডাক্টের দাম কি হইছে এটা আমি আপনাকে একটা মেসেজে দিয়ে দিয়েছি স্যার যেহেতু আসছে না
মিউট প্লিজ
Dr. Rupinder, please go ahead.
Yeah. Okay, so like, hello?
Yes, we can hear you. Okay, I think we have lost Dr. Rupinder and Dr. Goodman is not able to join.
Just
so,
one
I think
Dr. Amita, just one comment.
Yeah.
Santosh here.
Yeah, hi Santosh. Yeah.
I am, to be very frank, I'm hearing the term parametrectomy for the first time. I've never seen a specimen of parametrectomy.
Yes, because
you never do it. I don't know. So Rupinder madam might have done, but I don't think in DMH we have ever done a parametrectomy.
Can I just interrupt you? Just
Sure, please.
So, see, in all of my this 25-30 years of whatever oncology, I've done only 2 parametrectomies. A third one was done by a colleague of mine, and while she was doing it, she used a harmonic, and she took away the whole fundus of the bladder, and that was the end of it.
Yeah,
so,
now Santosh, you know why.
I know.
So now you know why.
Surprised to hear the term parametrectomy.
Yes, parametrectomy is more theoretical than actual, and even after doing a parametrectomy, you can be sure that you don't know how much of the tissue which you think is actually just parametrum, is just some inflammatory whatever you have, and not really the para, because the moment you've done a hysterectomy, the rest of it just shrinks away.
Yes.
So yes. And we must remember that if you are doing a parametrectomy, you need to take a long cuff of vagina, at least 2 centimeters. And believe me, you need a lot of surgical expertise to be able to do all of that post-surgery. That is one. And secondly, this kind of surgery you should do within 6 weeks of the previous surgery. So you have all of these things to say. And I think the patient is best off if you just give CTRT, which is good treatment, good management.
Right. So I think message is very clear here. One, if patient anyway needs adjuvant chemoradiation, one should not do surgery. in this case, if there was no morbidity, you were really lucky. Otherwise, doing another surgery, parametrectomy followed by chemo radiation, morbidity is huge. And in a patient where there is already an indication for a radiation, we should not do surgery. Highly selective cases, as Dr. Santosh just mentioned, we have rarely done this procedure at Tata Memorial Hospital for the reasons Dr. Rupinder mentioned. So it's something very, very rare, rarely done, at least in at our center. So, and there is a question, is there any advantage of parametrectomy over chemoradiation? So, Bhagya or Dr. Abraham?
Yeah, the advantage, advantage is if you can avoid radiation, then the late complications of radiation may be avoided. That's the only thing. So if you get the ideal case, and if it's, within a short time of the first surgery, then you could, and if you can do it, some people are doing it laparoscopically. So that's the only thing.
As Dr. Rupinder very rightly mentioned, it's technically very challenging procedure.
Yes, like I said, additions are going to be difficult. It's going to be difficult surgery. So.
Can I have a comment, please?
Yes, ma'am.
Professor Sabera Khatun.
Yes, madam.
But parameter in our country, many cases come with this history, with this type of history, that is simple hysterectomy done for cervical cancer without any evaluation of the cervical disease. And I have in Bangabandhu Sheikh Mujib Medical University, I have done, I think, not less than 10 cases, parametrectomy and vaginectomy, bilateral pelvic lymphadenectomy. But before going for this type of surgery, the patient needs very, very careful evaluation. MRI should be done, and then the I do examination. If it is the clinical examination is not complete and informative, correctly informative, in that case I do the examination under anesthesia, whether the parametrium, there is no thickening or shortening or induration of the parametrium, and there is no any lymph node by MRI. That after evaluation, if it seems that the surgery will be very easier and the patient is thin, lean and thin, in that case, if it is, I think that it is may not be very difficult, then I have done many cases, not less than 10 cases, parametrectomy, upper vaginectomy, lymphadenectomy. And somebody told that what is the advantage of doing parametrectomy? And parametrectomy, it can give some information about the parameter, because parametrium involvement, it will give some information. Lymph node involvement, it will give some information about the lymph node involvement. So actually, what is it will give the correct information, indication about the radiotherapy or concurrent chemoradiotherapy. So if it is possible, and the surgeon is very expert, in that case, I think Dr. Rifat Ara has showed that many times, that is when it is possible, the parametrectomy can be done. If it is
right,
not,
so only in highly selected patients it is
cases,
possible.
yes.
And the other thing is, if anyway indication for radiation, there is no need or no point doing parametrectomy and then giving radiation. Okay, so that's the message should be very clear. It is like upfront surgery. When you think patient would require radiation, please don't do surgery. Same principle here. Yes.
If there is clear-cut indication.
Comment and then we
just one small comment. See, everyone is talking of evaluation of the patient after the hysterectomy. Evaluation, how do you plan to evaluate such a patient? You want to do an MRI? The MRI will show you enlarged nodes, which might be inflammatory, which might be because of the disease. So there isn't any certain sure way. No imaging is really actually going to tell you, even if you do a PET.
It should be done after 6 weeks of surgery.
So, and trying to do a parametrectomy after 6 weeks, are you going to wait for 6 weeks? After diagnosis of the CS cervix, I'm not sure that is the correct way to do.
Right, I think we all agree that there are very few cases who would be appropriate and suitable for this procedure. The procedure is very challenging, and in case patient needs adjuvant radiation, the morbidity is going to be huge. So our preferred, at least in our country, in India, the preferred treatment is to give adjuvant radiation. I don't know if Dr. Bhavana is there, if we can have a quick comment from Bhavana, and then we move to the next patient, next case.
Yeah.
Yes.
I think rightly said by all of you. This patient, clear cut, she has indications for radiation upfront only, and it's an incomplete surgery. She should undergo chemoradiation. So this particular case is not for surgery, definitely. Would not help.
How often you see parametrectomy being done at your center? You have a reasonably high volume, right? So I think that's the policy across our country, at least, very highly
Amita,
selective case.
when I was at Mayo, we did a few, and I've also done a few in Vellore. But like I said, I'm very, very choosy. Very young patient, very early disease, where unlikely to receive radiation, I might do it.
Yeah,
Just to prevent, otherwise you will lose ovarian function and vaginal function.
Highly selected patients.
Very highly selected.
Actually for us, we would really select parametrectomy, especially when the patient has come after a week with a report of early cervical cancer and undergone NDVH, very common in our place. So in those cases, actually very lean patient and it's very early stage. So actually, as Amita has told, we have to be very, very selective. So we have got quite a number of cases after NDVH.
That's, I think, message is very clear. Let's, sorry.
Yeah, Amita, I like, it is not only the problem of our country, it is the problem of subcontinent. Without proper evaluation to proceed for operation and incomplete histopathological report also. So this is, this should be depends upon the resource and technical support in individual centers. So I like to say that just only early cases, those are only early case, no parametrial involvement, and just first case here presented that it was a case of CIN2 or HCIL, and everything free, parametrium free, no lymph node involvement, then we could select those cases only. Really early cases, stage 1A1, microinvasive cases for 1A1, A2 for parametrectomy and lymph node dissection. The aim should be no adjuvant. Right. First aim should be no adjuvant. This is the clear message, single modalities of treatment. So
absolutely.
Madam, yes. We are running late time. Madam, please. We are running late time.
Okay. So let's move on to the next case, I think. So yeah, so quickly to the next case presentation, please.
Thank you, Dr. Thank you, Dr. Rifat Ara and Dr. Sabiha Nigar. Our third case is, the presenter is Dr. Zubaida Gulshan Ara. She is from Rampur Medical College Hospital, and her case is on the basis of the history of subtotal hysterectomy with stump recurrence, how to proceed.
Thank you, Madam. Assalamu alaikum and very good evening. Next slide. My patient, Mrs. X, a 48 years old lady, para 4, living 3, housewife of a low socioeconomic condition, presented with post-coital bleeding for 3 to 4 episodes for the last 1 month and irregular paravaginal bleeding for last 3 months. On examination, she was mildly anemic and other vital parameters seems to be normal. On pelvic examination, a large follicular growth 4 cm diameter occupying the cervix, which was bleeds on touch, and bimanual examination, the left furnace was shallow and other formats are normal. Next. On rectovaginal examination, the left parametrium was involved. So from history and clinical examination, clinical stage carcinoma cervix stage 2B. On histopathology report shows squamous cell carcinoma grade 1. And ultrasonogram of whole abdomen shows a heterogeneous soft tissue mass measuring about 3.8 into 3 cm in the cervix. And chest X-ray shows normal study. Then oncologist was advised the patient for concurrent chemoradiation and ICRT, as there was no facilities for radiotherapy in Dinajpur Medical College Hospital, but patient declined as they do not have the financial ability to go Dhaka and stay Dhaka for about 3 months. Then she received his cycle of chemotherapy neoadjuvant up to 20 March 2021. She was then referred back to us for evaluation. And after giving now 4th cycle chemotherapy, she is now clinically well. On examination, a small growth about 1.5 centimeter in the anterior lip of the cervix. Uterus is normal in size, all fondness free, and both parametrium was free. Post-chemotherapy CT scan showed soft tissue mass about 18 into 20 into 20 millimeter in the cervix without parametrial or vaginal involvement, and there was no lymphadenopathy or ascites. Next. Then she was suggested to visit Dhaka for radiotherapy as best treatment option, but patient declined with same cause of financial condition, and detailed discussion with the patient was done, and decision of radiotherapy and then visiting was taken from the management. Now the patient is waiting for surgery.
Next.
Thank you for patient sharing.
Thank you, Dr. Jubaida Gulshan Ara from. And now I request Dr. Dilruba Yasmin, and she will present her evidences. Dilruba Yasmin, please.
Noman, share the screen. Noman.
Assalamu alaikum and very good evening. Now it is the time for evidence based in the role of anesthetic in cervical cancer, evidences and guideline recommendations in 2021. Next. In locally advanced cervical cancer, radiotherapy is the primary modality of treatment, but the use of anesthetic surgery has been considered to be an attractive alternative approach to primary radiotherapy to improve the disease control and reduce the toxicity. There is an original study by Neetu Ahirwal about the size of cervical lesion in locally advanced carcinoma cervix and responses to neoadjuvant chemotherapy. This is a prospective cohort study about 26 patients of locally advanced CS cervix of FIGO stage 2A, 2B, 3A, 3B with good performance status and without prior radiotherapy or chemotherapy. Cisplatin and paclitaxel based chemotherapy was used for a 3 cycle, and the efficacy of anesthetic was assessed includes operability status, downstaging, objective response regarding the tumor size. And the study concluded that if the tumor size is less than or equal to 4 centimeter, the complete response rate is 64.2%. If the tumor size is more than 4 centimeter, the complete response rate is 33.35%. And the stage 2B disease become operable in case of 60% of cases. There is the meta-analysis by Gaducio and Cascio in Italy, the neoadjuvant chemotherapy in locally advanced cervical cancer, review of literature and perspective of clinical research. They meta-analysis of 3 randomized controlled trials and showed that NSCT plus radical hysterectomy achieved better overall disease-free survival, locoregional disease-free survival, metastasis-free survival, and overall survival compared to definitive RT. Next. Next. There is a study about neoadjuvant chemotherapy followed by radical surgery versus no previous one. This is neoadjuvant chemotherapy followed by radical surgery versus concomitant chemotherapy and radiotherapy. Previous.
Yes, this one.
in patient with a stage 1B2, 2A, 2B squamous cell carcinoma. It is the first randomized controlled trial conducted in Tata Memorial Hospital by Sudeep Gupta, Amita, Maheshwari et al. And the study is a long study from 2003 to 2015. And the study include CS service on B2, 2A, and 2B. The primary endpoint of this study is disease-free survival without relapse and death of the cancer patient, and secondary endpoint is overall survival and toxicity. They conclude, they show the disease-free survival is significantly different in NSCT surgery group than concomitant chemoradiation group, and 5-year overall survival is similar in both groups. They concluded that cisplatin-based concomitant chemotherapy resulted superior disease-free survival compared with neoadjuvant chemotherapy followed by radical surgery in locally advanced cervical cancer. Next. Next.
Yes, this one.
Similar study was done by URTC trial 55994, randomized phase 3 study of neoadjuvant chemotherapy followed by surgery versus concomitant radiotherapy and chemotherapy in FIGO stage 1B2, 2A, size more than 4 centimeter, or 2B cervical cancer. This study shows significant differences between NSCT group and concomitant chemoradiation group, both in progression-free survival and overall survival. Next. Next, there is some guideline recommendation. The ESGO cervical cancer guideline recommended for stage 2B cervical cancer, definitive platinum-based chemoradiotherapy and brachytherapy. They studied no significant differences between NSCT followed by surgery and radiotherapy alone regarding overall survival, disease-free survival, loco-regional disease-free survival in case of locally advanced cervical cancer. Next. Next. Here the FIGO cancer report 2018. They show the NSCT. There is unanimity of view as the role of NSCT. There is unanimity of view as to whether it improves prognosis of the standard treatment. They concluded that NSCT surgery is best reserved in research setting or area where the RT is unavailable. Next. Next. The astroclinical practice guideline recommended that in neoadjuvant chemotherapy followed by hysterectomy has been studied to definitive chemoradiation in locally advanced cervical cancer. However, the RCT found superior disease-free survival with chemoradiation group. Therefore, neoadjuvant chemotherapy followed by hysterectomy is not recommended. So, from the above evidence and guideline, we can conclude that NSCT prior to surgery or CCRT is not a recommendation. It can be only tried for research purpose. Next slide. Next. Thank you.
Okay, so thank you for excellent presentations. And so my question to all surgical experts on the panel, where do you see a role of neoadjuvant chemotherapy? Do you practice neoadjuvant chemotherapy? And if yes, so who are the cases you would consider for?
AK is here, ma'am, AK.
Oh yeah, is she there?
Yes. Yes. She was on surgery, yeah. Now she's free.
Okay, so let me start with AK.
Yes.
Dr. Goodman.
AK, please unmute.
Meanwhile, Dr. Abraham.
Yeah, I think.
Oh yeah, here we go. I'm sorry.
Oh, sorry. Go ahead, Dr. Goodman.
Sorry, I was on mute. I apologize. By the way, thank you so much for the beautiful presentations. You know, I think the data suggests in the conglomerate that the best treatment is combined chemoradiation up front. I think that's the issue. This particular patient has a a tricky problem in that she has a cut-through hysterectomy with parametrial disease, a 2B. That puts her in a poor prognostic category compared to a 2B without a previous hysterectomy. And it may be, and I'm interested in the rest of the panelists' thoughts about this, that in the absence of the fundus of the uterus, the ability to deliver curative brachytherapy with a good radiation field is reduced. So you're starting with a very problematic situation. As was commented, this is unfortunately not a rare occurrence. And then on top of that, you have the issue of finances, and you have the issue of a queue to get into radiation. And that leads to the solution, which is neoadjuvant chemotherapy, right? Clearly, you do see a response to this. And Dr. Pervin actually looked at this data at NICRH, looking at the ability to operate after neoadjuvant chemotherapy on advanced disease. And so it is something that you can do, and potentially from a totally pragmatic point of view, that is something to consider. But I would just say that in an ideal world, you'd want to start with concurrent chemoradiation. Thank you so much.
All right, thank you, and thank you. Dr. Abraham, and then Dr. Bhavana.
I mean, we don't routinely practice neoadjuvant chemotherapy, but we do get patients, especially from Bangladesh, who have had chemotherapy. And we see that sometimes the tumor has completely disappeared. I mean, it's, some patients respond very well. So again, I would choose surgery only if for some reason radiation therapy is not possible, not available, or a patient is very young and she refuses radiation therapy. So very selected patients, young patients where, there's an advantage of surgery over. And like was shown in the trials, the long-term effects of radiation could be prevented with surgery. But again, since overall the recommendation would be chemoradiation as the first choice.
Right. So, Bhavana, do you see any problem if you have to give concurrent chemoradiation to patients who don't have uterus, body of the uterus, and only, such kind of stump carcinoma?
So we do get these kind of cases, once in a while. So what we do is we see, you can give brachytherapy if the cervical stump length is, as small as 2 centimeters, even if there is an absence of uterus, because we do have tandems and applicators where we can deliver the brachytherapy to that stump. So what we do is we follow these patients up with concurrent chemoradiation, and then we assess the cervical stump length either with a transvaginal ultrasound or an MR. And if it is 2 centimeters or more, we take them for intracavity brachytherapy. If not, we practice interstitial brachytherapy in these patients. So given by the evidence that is there in favor of concurrent chemoradiation in such cases, we do not advocate neoadjuvant chemotherapy. So that is a standard practice.
Dr. Kamaluddin?
Yes, Amita.
So how, do you see any challenge in such sort of cases if you have to give brachytherapy, and what would be your preferred treatment here? Would you give neoadjuvant and then send to Dr. Chana for surgery, or you will be comfortable doing upfront chemoradiation?
So first of all, in ideal world, I will prefer for chemoradiotherapy. Another problem that I would see that, say, I'm not sure by giving chemotherapy neoadjuvant, am I doing good or harm to the patient? That is a big challenge coming up, because there are some data that maybe it is, yes, it becomes operable, we can do some surgery, that is one scenario, but there is another scenario where we may create some chemo-resistant clone also. So as long as we don't have strong data in favor of neoadjuvant chemotherapy, I'm in favor of going for upfront chemoradiotherapy, number one. But yes, if there is any scenario where patient is reluctant, cannot go for surgery, that is a different thing. They not go for chemoradiotherapy. There is a different scenario, but we should not carry a wrong message that this is an alternative to chemoradiotherapy. Neoadjuvant chemotherapy still, by scientific basis, cannot be an alternative to chemoradiotherapy. It can be I mean, the poor man's regime, or we can do the weak recommendation in very low resource setup. Even you see, ESCO have given the protocol guideline that in resource setup limitation they can do, but they have revised it after your RCT publication. They have changed it. So there is no definite recommendation now. So in compelling circumstances, yes, but I'm not practicing and I'm not recommending it.
Right. So in we also, I mean, we don't practice it either. The question is, if some people argue in favor of neoadjuvant and surgery, saying that if there is no brachytherapy facility, do you think that's a valid argument to not to give plan for concurrent chemoradiation?
Amita, again, the question is, if you look at the outcome data, the wonderful outcome data is in early stage with neoadjuvant and surgery. But when the brachytherapy comes in our country setup, we hardly get this early stage patients. So with those patients, when we are giving neoadjuvant chemotherapy, then doing the surgery, maybe we will end up that again the patient will need some radiotherapy. So try modality, neoadjuvant, then surgery, then go for radiotherapy. So we cannot avoid it in most of the cases. So,
right. So yeah, in our trial also nearly 40% patients required either definitive or adjuvant radiation in neoadjuvant chemotherapy surgery.
So that's why I'm not in favor for
that. Dr. Bhavana.
But I think, Amita, you are working in the ideal world, but we have to also look at some real world situations in which in my state, patient has got a radiation date after 4 months. So do you think we'll wait for those cases?
Yes.
What is your opinion?
That's again, very emotional kind of situation. What to do if patient has to wait for 4 months? Do we give neoadjuvant? But I don't know. Dr. Kamaluddin, you answer this.
I want to know, Dr. Bhavana.
Bhagya, so answer to your question is, again, I'm in favor of doing some treatment, but I need to be very sure that I'm doing some good. In head and neck cancer, if you give chemotherapy, it will disappear and it will come back. In cervical cancer, there is a Brazilian data that neoadjuvant chemotherapy followed by radiotherapy caused detrimental effects. So it is a big psychological stress for not treating a patient, keeping her waiting. But on the other hand, if the patient is reluctant, is pushing you to get some treatment, as the oncologist or a physician, we need to know, are we really doing good or bad? So in the sake of only treating, we should not treat unless we have definite evidence. In our country, there is also queue of 4 and 5 months. And in the name of that waiting time, we also practice in some centers neoadjuvant chemotherapy. But honestly, we really don't know, are we doing good or harm to the patient? That is I don't know whether there will be any trial ever it will be conducted to see.
So I don't think any ethics committee will ever approve such a trial where you deliberately tell people to wait for, it will be unethical to conduct such a trial.
So I have a question to Dr. Bhavana.
Yes, Dr. Shahana, please.
Yeah. In that case situation, in what Dr. Bhagya has mentioned, that in our center, also the patient queue is minimum 4 months, sometimes it is 5 to 6 months. In that situation, if you are facing this situation, what will you do? Dr. Bhavana, please. And their patients are so poor that they cannot go to the private center to have the financial ability to do the chemoradiation to receive from the private center. Bhavana, in that situation, what will you do for those patients? And there is a large number of patients where there is a long queue.
I think we aren't left with much option in that situation. But like Dr. Kamal said, we should not first think it as an alternative. As far as possible, we should try and refer these patients. See, patients are going to be spending money for the chemotherapy as well.
No, they are getting this from the hospital. They are getting hospital supply, government supply.
No, I think waiting 6 months is just too much.
Yes,
the difference between the trials is not that great. Even in the Tata trial, overall survival, there was no difference. Disease-free survival is only 5%. And to make patients wait 6 months is not ethical.
Minimum 4 months.
We should not take this as an alternative.
Yes.
As far as possible, the patients should be referred for radiotherapy. But I know of quite a few centers in India, also enough reputed centers where it is not possible to get a date for almost 3 months. in that case, we cannot say that it's an ideal treatment, but yes, we do not have an option. So that is the reason we would go in for neoadjuvant chemotherapy.
Bhavana, I want to add with Dr. Abraham that the comparison was neoadjuvant followed by surgery, but what we are discussing most of the time is neoadjuvant followed by chemoradiotherapy. So this is an unresolved issue. There is no data about that because all these waiting patients will never end up in surgery. They will go to chemoradiotherapy.
Yes.
So after 3 months or 4 months, getting 4 or 5 cycles, they will go to chemoradiotherapy and get treated.
Yes.
So we really don't know that during this waiting time, when we have given the chemotherapy and then landed in the chemoradiotherapy, because the trial that Tata done, URTC, is neoadjuvant followed by surgery, not neoadjuvant followed by chemoradiotherapy. So taking that data of 5% or a DFS or small OS benefit, we are discussing the issue different, that neoadjuvant followed by chemoradiotherapy. So it is a totally different scenario. I think that is the biggest challenge in our area. Where there is a resource of chemoradiotherapy, there is also a resource of radical hysterectomy also. Qualified surgeons and the queue of the surgery is also there. So I think we should not mix up these two scenarios. One is NSCT followed by surgery, another is NSCT followed by chemoradiotherapy.
Yeah,
so in fact,
can I just make a point? See, since about 10 years now, we are also not giving any neoadjuvant chemotherapy. But before 10 years, we were giving neoadjuvant chemotherapy to patients and we were doing radical hysterectomy. In fact, a paper was published from our center wherein we had done this for about 76 patients. The result was that 40% of them achieved a complete pathologic CR so that they were not given any adjuvant treatments. Neoadjuvant chemotherapy followed by radical surgery and left for follow-up. But 60% of them did require adjuvant radiation. So keeping that point in mind, we are no longer practicing this neoadjuvant chemotherapy followed by surgery.
So I think, yeah, there is...
No, 1 minute. See, having said that, still, I do feel there is still some role of neoadjuvant chemotherapy followed by surgery for a very, very small select group of patients. Number one, those who have to wait for a long time. The parametrum is soft and the young patients. And another advantage would be that you can transpose the ovaries and save the patient any kind of ovarian ablation. That too goes if we do surgery followed by NSCT. Though, of course, they say once you've given chemotherapy, in any case, you've already damaged the ovaries. So, I mean, it's a very tricky kind of situation. And patients where we would practice, there would be very, very few.
So I think, ma'am, the message should not go that this can be an alternative. This is only a last.
No, it's not an alternative.
No, I think we all agree that chemoradiation is probably the what we should recommend.
Choice, yeah.
But I just want to ask Amita, how convinced are you about this 5% difference in disease-free survival? Because your paper said that there was no difference in overall survival and the radiation effects were more. Complications due to radiation were more. But you concluded that disease-free survival was better in the...
right. So, the thing is, in 2 it was definitely detriment. In 1B2 or now 1B3, there wasn't any difference. But when we talk about toxicity, actually it was vaginal toxicity, which was slightly more in radiation arm. Otherwise, there was not much difference between toxicity between the two groups.
When bladder and rectal, your paper said bladder, rectal and...
No, so long term, no, long term only vaginal was more. Otherwise, there was no difference in toxicity. Interestingly, what I recently got to know, in fact, it's from a friend from UK. She said until recently for all 1B3, they were doing concurrent chemoradiation. But after our paper, in fact, their group now they are discussing whether any CT or surgery should be done because there is no difference in survival between two arms. So, how you interpret results, it's very, very individual. So yes, but what message we go like coming back to the practice of NACT because of waiting period. Is it correct? Do we recommend that practice? What do we what's the conclusion from this discussion?
I think waiting 6 months seems. Suppose in some centers like in Africa, radiation is not available. And even in India, radiation facilities are not available, though it's improving. There is a lot of improvement. And waiting 6 months, to my mind, seems crazy. I mean, we should work towards improving that situation.
I think that's the most important thing, that we should work making radiation facilities more, widely available. But we really don't know while waiting for radiation, do we give radiation, give chemotherapy, or do we just wait for 6 months? Of course, it's unacceptable. But if it's 2 or 3 months, whether we just wait or give a neoadjuvant chemotherapy. Because as Dr. Kamaluddin very rightly mentioned, there are few trials, NACT and radiation, which have shown detriment in patients who receive neoadjuvant chemotherapy prior to radiation. And the explanation possibly is selection of radio-resistant clones. So I think on scientific ground, we cannot recommend this practice. But I think logistics, and we really don't know. Maybe a good idea to look at our data. If you are routinely practicing this, Dr. Shahana, maybe a good idea to look at the data and outcome of these patients who receive neoadjuvant chemotherapy prior to radiation therapy.
Yes, ma'am. Thank you.
I mean, waiting 2-3 months may be okay, but more than 3 months, I don't know.
I think there should
the
be
line
some
somewhere.
guidelines, how long it's acceptable for patient to wait.
So maybe we can see
definitive
what is the
treatment
grade
is.
of the tumor. If it's a poorly differentiated tumor, 2-3 months would be disastrous.
Yeah.
Shahan, I think we can move
Excuse
to our
me,
next.
excuse me, just 1 minute. Can I add?
Yeah, yes.
All right.
Yes.
Actually, the FIGO cancer report 2018, they also recommend that where the facility of radiotherapy is scarce, there we can just practice. Obviously, concurrent chemoradiotherapy is the category 1 evidence, but where there is no facility of radiotherapy or patient needs to wait for a long time, there we can suggest NACT to reduce the size of the tumor and to increase the operability of that patient. This is one thing. I think we can, in our context, in Bangladesh, as most of the patient, they have a long queue, more than 3 months. Then in selected case, we can suggest, but of course it is not alternative therapy.
Right. So I think this is very clear, and I would.
And Dr. Amita, one question to you. Do you suggest NACT in pregnancy with cervix?
We do suggest NACT in pregnancy, and we have given to a couple of patients. So I think the message is very clear. Standard, we know. NACT should not be used as a routine, only in very specific situations where patient definitive treatment is not possible immediately. Then I think NACT may be considered.
Yes, so, we'll go for the fourth
To
case.
the next.
Fourth case. Next case.
No man. Next case.
The next presenter is Dr. Ishrat Jahan. She is from Sylhet MAG Osmani Medical College, and the case will be related on the carcinoma cervix with history of 3-cycle NST. How to proceed?
Am I audible?
Yes.
Respected faculty, Assalamu alaikum, a very good evening. I am Dr. Ishrat Jahan from Osmani Medical College Hospital, Sylhet. This case was treated in the Greater Sylhet region. Mrs. X, a normotensive, non-diabetic, multiparous lady of 50 years, attended at GOPD on 12th March 2021 with complaints of irregular pervaginal bleeding for the last 3 months and lower abdominal pain for the same duration. The patient informed us that she had undergone a surgery 3 years back, but she could not mention the name. But she could show us the discharge paper and an ultrasonography report which had been done before the surgery. According to the discharge paper, total abdominal hysterectomy was done in January 2018. The ultrasonography report, however, mentioned it to be a fibroid uterus. Next slide. There was no detailed operation note in the discharge paper, and according to the patient, histopathological examination of the resected specimen was not done. Her post-surgical period was uneventful till 3 months after the operation. She did not undergo any screening procedure for cervical cancer. Her bowel and bladder habits were also normal. On general examination, the patient was mildly anemic, the breasts were normal, and so were the vital parameters. A transverse scar was present on the lower abdomen on per abdominal examination, and per vaginal examination revealed that the cervix was visible. An exophytic growth of 2 into 1.5 centimeter was present on the upper lip of the cervix. Both the parametria were free. We communicated with the primary surgeon who informed us that her initial plan for the surgery was to perform a total abdominal hysterectomy, but owing to severe perioperative bleeding, a subtotal hysterectomy was resorted to. Upon investigation, her hemoglobin percentage was 8.9 gram per deciliter. The liver and kidney function tests were normal, and so was the chest X-ray. An MRI of the whole abdomen showed that the uterus was absent and a soft tissue mass of 2 into 2 centimeter was present in the vault area, and there was no pelvic lymph node enlargement. Histopathological report of the cervical tissue revealed an invasive squamous cell carcinoma of grade 2 differentiation. Thank you. Thank you.
Sorry, it was in squamous carcinoma. Now I request Dr. Rumana Afroz to present her evidences. Dr. Rumana, please.
Assalamu alaikum and good evening to all. Here is my evidence-based presentation on stump carcinoma, cervical stump carcinoma. Cervical stump carcinoma are rare nowadays as subtotal or supracervical hysterectomy are becoming rare procedure. More than 2 years following subtotal hysterectomy is considered to indicate true cervical stump cancer, but if the time difference is less than 2 years, it is considered as coincidental carcinoma that may have been present at the time of hysterectomy. It accounts for 2 to 5% of all carcinoma cervix patients. Next. Material history and patterns of spread are similar to those of the cervix with intact uterus. The symptomatology, stress distribution, diagnostic workup, clinical staging, and basic principles of therapy are same. Next. Zhenshen et al. Performed a retrospective analysis of early stage stump carcinoma. Total patient was 20, and aim of the study was to find the treatment outcome. His study showed that mean patient age was 52.4 years, 80% of the patient was squamous cell carcinoma, and 20% cases it was adenocarcinoma. All these features completely correspond to that of classical carcinoma cervix. He also showed mean time interval between subtotal hysterectomy and development of stump carcinoma was 11.4 years. Next. Among 20 patients, transvaginal trachelectomy was done in cases of carcinoma in situ patients, and radical trachelectomy and pelvic lymphadenectomy was done in case of early stage invasive carcinoma. Mean follow-up time was 33.2 months, and no cases of recurrence were observed. Next. Bailot et al. Reviewed 213 cases of stump carcinoma, which represented 5.5% of the cervical carcinoma diagnosed during same period. According to him, mean time interval between surgery and stump carcinoma was 17.6 years. In his study, most of the patients were in FIGO stage 2B, 27%, 25% were in stage 3B, and rest were in stage 1. 77% of the patients received radiotherapy alone. Surgery alone was done in 5% patients, and rest of the patient received combination therapy. Next. The author concluded that there is no significant difference in locoregional culture between radiotherapy radiotherapy alone and surgery alone or in combination. But lethal complications are more in surgical group, 6%, than in radiotherapy group. Next. So now what are the guideline recommendations? The ESMO and ESP guidelines recommends that management of cervical stump cancer follows recommendations for patients without previous subtotal hysterectomy. Adaptation for radiotherapy may be necessary, in particular for brachytherapy. So principles of treatment are same as those for intact uterus with emphasis on brachytherapy in the recommendation. Next. And Catherine, in her study, Carcinoma of the Stump, 50 years experience, reviewed 161 patients of cervical stump carcinoma. It represents 2% of the carcinoma service patient diagnosed during this period. Aim of her study was to find the survival of the stump carcinoma patient and compare it with the survival of classical cervical carcinoma patient. Next. And he showed that there is no survival difference between stump carcinoma and carcinoma cervix. Next. But he also showed that adenocarcinoma has poorer survival than squamous cell carcinoma, which is also a fact for the case of classical carcinoma cervix. So he concluded that 5-year survival rate of patient with cervical stump cancer compares favorably with patient with intact uteri. Next. So to conclude, cervical stump carcinoma should be treated in same principle to that of carcinoma cervix with intact uterus with special attention to radiotherapy. Treatment provides similar locoregional control and survival at equal stage in stump carcinoma compared to carcinoma in intact uterus. And we should avoid subtotal hysterectomy. Screening should be continued after subtotal hysterectomy. Thank you for patient sharing.
So thank you, Dr. Afroz and Dr. Ishrat Jahan for excellent presentation. So AK, this lady is with you now. What will be your plan for her? Dr. Goodman?
Yes, so you have a patient with a carcinoma of cervical stump.
Yeah, so the thing is two things. One, you know, this lady had a growth which was not biopsied before the first surgery. Someone just thought of doing hysterectomy again. You know, we want you to reiterate the importance of pre-treatment biopsy and evaluation. And now what will we do for this patient?
Right. So I was actually reflecting that, just to pull it back for a minute and just think about the big picture about training and education of doctors who care for women with gynecologic disease. So that would be OBS-GYN, right, in general. And around the world, training programs vary, but maybe when it comes to surgical teaching, one very important message should be that there is very rarely a role for a supracervical hysterectomy. So we'll get back to the issue of biopsying and cancer diagnosis and so forth. But I think if we start with training our young ones, you know, to say nowadays with modern surgical technique, there is really no role for a supracervical hysterectomy. Let's just pull it back and say, why were supracervical hysterectomies done in the past? And why should that not be something we, in general, consider doing surgically, whatever the indications for surgery are? And I think in the past, the one reason that supracervical hysterectomies were done was because of lack of training, okay? If you think about where is it that you get into trouble on a hysterectomy surgically, it's really that part, uterine artery down, right? Above uterine artery, pretty easy peasy. You cut the round ligaments, you either take the ovaries, you don't take the ovaries, and there you are. And at that point, you can just lop off the top of the uterus and maybe close up what's left and go home. But the technical part of a hysterectomy is separating the bladder, is being sure you don't have a ureteral injury and so forth. So that's really where you get into trouble, and then post-operatively, ureteral injuries, post-operative bleeding usually comes from the vaginal angles and so forth. So when we're training our young doctors, all right, that's really technically, and Amita, your beautiful, beautiful videos on previous sessions always just make my heart sing, because you go through all these techniques so very clearly. But so the reason in the past, it was like 1950s, 1960s, you know, I don't even know, prior to my lifetime, but what we've inherited is a group of people who didn't have that training surgically. There's no excuse for that anymore. You know, I've had the privilege of visiting Bangladesh so often. I see what beautiful educational systems you have there. So that's a big plug for that. There is a reason.
Just to interrupt you for a moment, I think, popularization of laparoscopic surgery again brought back this culture of supracervical, because, you know, that part is little tricky at laparoscopic surgery. So we were seeing more supracervical because of laparoscopy. So yeah, please continue.
And there was a time when they thought sexual function would be affected, although there have been studies to show that it's not so.
Yeah, exactly. I think these were
for that.
Yes, I think laparoscopic surgeons, because they were looking for an excuse to do supracervical. I think that's how studies came showing that sexual function, cervix is important for sexual functions. Yeah, please continue.
Right. No, that's beautiful. And thank you also for that comments. There's, I call them urban legends. That's sort of the expression that we use when we have this mythology, and one is sexual function and the other is prolapse, right? And those are the two mythologies about preserving the cervix. But even before then is the issue of technical. And you're absolutely right, Amita. It comes back again in laparoscopic surgery and the importance of separating the bladder. However, just to say, you know, to the young ones, there are for sure reasons why we do supracervical hysterectomies, and usually there's situations of dire and emergent life-threatening hemorrhage, usually in an obstetrical case, where you're saving that woman's life by tying off her uterus and taking out the uterus, and you don't even care about that cervix. That's not what's killing her, right? But beyond that one situation, our OBS-GYN surgeons need to learn how to do a full total hysterectomy, and it should be implanted into their brains that a supracervical is a no-no unless it's a dire life-threatening emergency. Okay, so that's my one comment. Okay, I could go on. Clearly, I have a rant about that. But in the issue of someone coming in with bleeding, and we've talked about this before, it is de rigueur. It is absolutely what we need to do. We need to do a pap smear. We need to do a visualization. If we see a lesion, it needs to be biopsied. Even if we don't see a lesion, we need to do an endometrial biopsy. And that's a very standard evaluation in the outpatient clinic and the outpatient department. So it's sad when someone gets a hysterectomy for bleeding without any evaluation, right? And again, it probably is something attributable to perhaps a lack of training. And so for all the teachers in the room here, and I know there's many eminent teachers that you all are blessed with in Bangladesh and in India, is that these are the two messages. But now you have a tricky issue with this stomach cancer, and I think the previous conversations still apply here. That conversation, I mean, I thought what Professor Sabera Khatun said earlier was brilliant, you know, is that you do radiation and chemo mostly. It's rare to do a radical parametrectomy, upper vaginectomy, but you can, if you have the skill set for it, if you're trained to do it, and it's appropriate, get an MRI first. So those are my comments, but I want to hear from other people too.
Yeah, so I absolutely agree, and brilliant comments, Dr. Goodman. Thank you so much. Maybe Bhagya and Dr. Abraham, and what will be your approach? A lady who had to undergo subtotal hysterectomy because of intraoperative bleeding and now got cervical carcinoma diagnosed, confined to the cervix. So would you prefer a surgical approach or concurrent chemoradiation?
I think If everything is fine, we would do a surgery, of course.
You would do a radical trachelectomy, right? I mean, the surgery, in simple words, it would be a radical trachelectomy. I absolutely agree with you. Dr. Abraham?
Yeah, again, we need to assess whether it's a surgical candidate or not. I mean, if it's early stage and young patient, I would prefer surgery. But of course, you know, I might do, you know, imaging and a proper clinical examination would be necessary before you decide.
So, Bhavana, do you see any issues with radiation in this patient? Would you change your radiation plan or would it be as, you know, when you do for a patient with uterus intact?
Yes, like I said before that we do assess cervical stump length, and that's what helps us decide whether this patient will go in for intracavity brachytherapy or interstitial brachytherapy. But external radiation remains the same. And I guess for such patients, we do expect more GI toxicities with the external radiation also, as compared to a patient with an intact uterus. So these are the points that we take into consideration while deciding the treatment in such cases.
I think we agree that if it's an early lesion, a radical
Yes.
trachelectomy with
Yes,
lymphadenectomy
definitely.
is preferred. But if not, then we would definitely send this patient for concurrent chemoradiation.
Yeah.
So before we move on to the next case, we have a couple of questions in the chat box. Let me ask you, Bhavana, since you are there, a lady who has received, who was planned for definitive chemoradiation, ended up only with EBRT because of COVID. And 6 months later, she is with you. Clinically, there is no disease. She has not received her brachytherapy. EBRT was over in 6 months back. What would you do?
Okay. Dr. Amita, I would not spare any opportunity of giving brachytherapy.
Okay.
Yes.
Dr. Kamal? 6 months later, no disease after EBRT, would you observe or give radiation, brachytherapy to this patient?
That is, you know, you can opt both the way because as Bhavna said, well, it will be tempting to give brachytherapy, but if somebody wants to avoid it, there is some logic to avoid it also because we are not sure about after 6 months whether such a huge gap, if brachy is going to give any benefit or not.
We have such type of case discussion. In last case is like this.
Case like that. And the
Yes.
last case is like that. We can discuss on that case.
Oh, okay. It was in the chat box. So, okay. So, quick question for you, Bhagya. If cervix is flushed and biopsy, colpo-guided biopsy is CIN3, you can't take a leap. What will you do?
I think Bhagya is on phone. Can Dr. Abraham?
Okay. I think then we move on to the next case, and we'll ask her once she's back.
No, I would, yes. Can I answer that?
Yeah, please.
Yes, please.
I mean, if you can't do leap in the OPD, you can take her to theatre and do a cone.
No, so the thing is, it's absolutely old lady with flushed cervix. We do see those cases, 60, 65.
But it can always, it might not be a great cone, but some sort of a ring biopsy or a very shallow cone, something is possible in theatre. I mean, she may not cooperate in the OPD. We can take her to theatre and do it. But again, I think that message, we cannot do hysterectomy without screening for cervical cancer. We cannot do hysterectomy for CIN without doing a proper cone.
Without ruling out invasive cancer.
Invasive cancer. Yeah. So these 2 points have to be stressed.
Let's move on to the next case.
Okay, Shahana, next case.
Our next case is from Faridpur Medical College, and the presenter is Dr. Swapna Vishwas. And the case scenario is the.
Thank you, ma'am, and very good evening to all.
Swapna, yeah, the case scenario is on the basis of paroperative large lymph node, whether to continue or abandon the surgery in carcinoma cervix. Yeah, Swapna.
Thank you, ma'am. Thank you, ma'am. Next slide, please. My patient, a menopausal lady of 49 years, mother of 5 children, wife of a rickshaw puller, hypertensive, non-diabetic, attended to GOPD at Faridpur Medical College Hospital on 2nd February 2021 with the complaints of foul-smelling vaginal discharge for 6 months and postcoital bleeding for 2 months. Her ECOG performance status was normal. On pelvic examination, an exophytic growth about 2.5 into 2 cm involving both lip of the cervix, which was hard, fixed, friable, and bleeds on touch. Vagina was not involved. Uterus was normal sized, anteverted, and mobile. Parametrium was smooth and free. Both adnexa were normal. On rectovaginal examination, both parametrium were free. Rectal examination, rectal mucosa was free. Then biopsy was taken from the growth and report was invasive squamous cell carcinoma grade 2. Then metastatic workup including routine blood investigations, USG of whole abdomen and chest X-ray was done. Chest X-ray was normal. Next slide. This is the ultrasonography image and it revealed a hypoechoic mass confined to cervix, no parametrial involvement and no lymphadenopathy detected. Next slide. So she was diagnosed as a case of squamous cell carcinoma of cervix, stage 1B2, grade 2. And she was planned for radical hysterectomy and bilateral pelvic lymphadenectomy. So on 1st March 2021, abdomen was opened by malar incision and checked for operability. Few enlarged lymph nodes were seen. One lymph node about 1.5 cm found fixed with underlying vessel. Then blunt surgery was completed, keeping behind the fixed node, considering risk of vessel injury. Next. This time, histopathology report revealed squamous cell carcinoma grade 2, tumor size 3 cm, parametrium not involved, vaginal cuff free, 10 nodes were dissected, 3 were positive, LVSI positive. Next. Then the patient was referred to oncologist for further management. Next. Thank you to everybody.
Thank you, Dr. Swapna Bishwas. Now I request Dr. Sabiha Yeasmin to go through your evidence-based presentation. Sabiha Yeasmin, please.
Am I okay, madam?
Yes.
I'm Dr. Sabiha Yeasmin, presenting today's topic. The finding of positive pelvic lymph node at the time of exploration for radical surgery presents a challenging decision, whether we complete the planned hysterectomy knowing that the patient will require further adjuvant therapy or abandon the procedure for primary chemoradiation. The management of patients with intraoperatively detected positive pelvic lymph nodes remains controversial. A combination of extensive surgical dissection followed by pelvic radiotherapy associated with higher morbidity without improvement of survival. So the treatment goal is to identify the most appropriate method of management to avoid multimodal therapy. A paper published in International Obstetrics and Gynecology Journal by Hedy J. et al. On 2010, here total number of cervical cancer patients were 268. Abundant hysterectomy for finding grossly positive pelvic lymph nodes were 19, that is 7%. Major morbidities were found 26% in abundant group compared to 34% in completed group. Recurrence rate were 37% in abundant group compared to 18% in completed group. Overall survival in the abundant group was 73% versus 80% in the completed group, which was not statistically significant. Gynecological oncology group have done a study on 2000 and they also abandoned the radical hysterectomy surgery for the patient who have found intraoperatively positive pelvic lymph node, and the groups were then abandoned, surgery was abandoned, and patients were under treated for concurrent chemoradiation. They have concluded
Yeah.
They have concluded that the disease-free. They have concluded that the disease-free survival was shorter for patients whose radical procedure was abandoned than for those patients who underwent radical hysterectomy. This is another study done by Selim Abraham et al. On 2017, published in World Journal of Surgical Oncology. They compared the prognosis of patients whom radical hysterectomy was abandoned and bilateral pelvic and para-aortic lymphadenectomy was done with that of patients who were only biopsied and treated with concurrent chemoradiation. They have found no difference in overall survival or in disease-free period. In 2020, Kibula et al. Published their paper in European Network of Gynecological Oncology Trial Group, that is the APRAX multicentric retrospective cohort study. This is the objective of this study was to determine if the performance of radical hysterectomy improves oncological outcome in patients with intraoperative detection of lymph node involvement comparing to chemoradiotherapy alone. They also evaluate if a potential survival benefit of radical hysterectomy is modified by prognostic parameters that are tumor size, histological type of metastasis, presence of lymph vascular space invasion, number of involved lymph node. It was a multicentric study analyzed in 19 countries and 51 institutes over 10-year period of time. Total number of patients were 515. There were two arms, that is, one is completed, the radical surgery was completed group, and the another arm was where the radical hysterectomy was abandoned and patients were treated by concurrent chemoradiation. Primary endpoint is recurrence-free survival, and secondary endpoints were overall survival, pelvic recurrence-free survival, subgroup analysis according to prognostic factors. And here you can see that recurrence, if we analyze the recurrence and death between two arms, there is no significant difference. If we look at the curve, we can see that the two curves of these two arms are crossing or overlapping each other. That is, there is no significant difference in between two arms. So their recommendation is, if pelvic lymph node is involved or found intraoperatively during surgery, abandon the surgery and patient should consider for definitive chemoradiation. So there is still a controversy in the literature between continuing the surgery or abandon the surgery. Now we can see facing all of these controversies in the study, we can see what the guidelines are saying. The ESCO and European Society of Pathology gives a common point of recommendation. That are, here we can see the recommendation about negative lymph node on radiological staging. Next. If lymph node involvement is detected intraoperatively, including macrometastasis or micrometastasis, further pelvic lymph node dissection and radical hysterectomy should be avoided. Patients should be referred for definitive chemoradiotherapy. Para-aortic lymph node dissection, at least up to inferior mesenteric artery, may be considered for staging purposes. This is the guideline from NCCN. Next. This guideline also gives the same recommendation, that is abandon hysterectomy and patient should undergo chemoradiation. Next. So take home messages are, adjuvant chemoradiation is required for the completion of treatment after hysterectomy with node positive cervical cancer patients. Radical hysterectomy completion does not improve oncological outcome of lymph node positive cervical cancer patients. Dual modality of treatment causes additional morbidity. And chemoradiation therapy and brachytherapy is challenging in more post-operative patients due to absence of intact uterus. If lymph node involvement is found intraoperatively, abandoning further radical surgery, and patient should refer for definitive chemoradiation, and this is the recommendation. So thank you for patience hearing.
Thank you for excellent presentations. So let's start the discussion. And before I come to clinical part, Dr. Santosh, are you there?
Yes, I'm here.
Yeah. So Santosh, what's your opinion on the role of frozen section in surgical management of cervical cancer? How comfortable are you reporting on lymph nodes on frozen section?
So reporting on lymph nodes is not an issue because we get so many lymph nodes from various other sites also. So finding a metastasis at frozen section is not an issue. The query I had, a query or maybe a question or a doubt which I had, in micrometastasis, do we really abandon, Dr. Amita? We have had cases where we have had very small metastasis in the nodes sometimes.
Right. Yeah, so we don't, I mean, if we detect it intraoperatively, we abandon.
Yes.
The thing is, yeah, so whether it's micro, macro.
So finding a metastasis at frozen section is in pelvic nodes is not an issue, is usually you find it. And most of the times, if the node is enlarged, we do easily find the metastasis. Only the micro metastasis sometimes can be missed at frozen section because we usually take one or a couple of sections and we usually sample the largest nodes, not the smallest nodes. So that's the only issue at frozen section.
Right. I think we have an excellent backup, but I don't know if everyone is fortunate to have Santosh at their center, but we are definitely very lucky to have you and other colleagues.
Thank you so much.
Give excellent reports. So, okay, let me come to surgeons first. So this patient, what will be, in this patient, they continued with the surgery and left behind the node which was stuck. But what would you, your plan if you encounter such a case? What would you do? Bhagya? Dr. Rup, anyone can answer. I can't see actually who are there.
Okay, Amita, I'll take the question. No, I mean, the arguments for continuing with surgery is that, I mean, there's no point doing half surgery. You have to remove the node. If you can't remove, then you should abandon everything. But if you can't remove the nodes, the argument for removing the uterus is that you could probably reduce the amount of external beam radiation to 45 gray. You could avoid brachytherapy, especially with intermediate risk factors. That was the argument. I was just looking at the,
No, but Dr. Abraham, node positivity makes it high risk anyways.
Yeah, no. I was just saying that if once nodes are positive, you can, she will require radiation, but the argument is that you can give 45 gray and avoid brachy. That's the only argument. I'm not saying that you can avoid radiation. So looking at the results of even the ABRAC study, it's equal.
Right.
So why take the decision to not do surgery unless the complications of radiation? So I would like to know from Bhavana, with the modern techniques, are the complications of external beam radiation that much more just because the uterus is removed? So that is the only reason why you would abandon. Otherwise, it's both the same. So why would you want to abandon unless the complications are more? So, I mean, I agree with the trend now is to abandon. And but I'm not because I'm just looking at the guidelines are to abandon, but what are the conclusions we take from studies? I mean, we look at only one aspect, like the same thing I made with your the neoadjuvant argument. I mean, you have to look at can you avoid destroying the ovarian function? What about the vaginal function? So these are many aspects have to be considered. Is radiation therapy available? So all those things have to be taken into consideration, not just one aspect.
Okay. It's going to be interesting because it's a debatable issue. I agree. Bhagya?
It is also
I think it's an ongoing debate.
Dr. Rupinder is back. Okay.
Yeah. For me, at least, if we have opened, usually the dictum is that we go ahead and do the surgery if it is operable case, if everything is fine. And of course, sample the parotix also. But because we have learned from experience that if we abandon these cases and there's some kind of complication that happens later, some wound infection and the radiation gets delayed. So I think from experience, I know it's a very debatable issue. So, but still, if it's 1 or 2 nodes, and we are confirmed that they are metastatic nodes, so better we confirm them with frozen section, because in our part of the continent, we could also have enlarged nodes due to so many other causes. So we have to be.
My argument is, Bhagya, if regardless you are going to go ahead with surgery, why to burden your pathologist and put them under pressure?
Yeah, in case you think you are going to abandon, so the multiple metastatic and matted nodes, and in those cases, I think if you are thinking not to operate on the for the better thing of the patient, so in those cases you can do that. But in case this 1 node or 2 nodes looks large, little suspicious, I think we go ahead with surgery.
Okay, Dr. Rupinder and Dr. Goodman.
I thought the dictum was that if it's an enlarged node, in fact, remove the enlarged node, but abandon the surgery. No, remove the enlarged node and abandon the surgery, and definitely sample the para-aortics as well. So that is what we would do, especially when you're doing robotic surgery. Now, of course, for CS cervix, we is completely abandoned. But when we used to do robotic surgery for CS cervix, any enlarged node we would sample and send it for frozen, and if found positive, we would abandon surgery.
I mean, enlarged node you would find on imaging. So there itself, it would get screened out. I mean, we are talking about normal looking nodes which are sent for frozen section.
The other point actually I wanted to quickly touch upon is what is the appropriate or optimal imaging in operable case, because most patients here had only sonography. So of course we know limitations of MRI and CT in picking up nodes, but are we happy doing only ultrasound for 1B2 or 1B3 lesions?
No, I think MRI would definitely need to be done, or at least a CT scan, because ultrasound is really not adequate. But then again, the question comes, if you don't have MRI, if you don't have CT scan, then we are left with opening up.
Okay.
Amita, I just want, I am, pardon my ignorance, but abandoning a surgery in a micrometastasis, is there enough evidence? You have a single tiny node which has a micrometastasis.
Generally, micromets are not being picked up on frozen section, but if they are, then yes, we would abandon the surgery. The argument is that this patient anyway would require concurrent chemoradiation.
But the evidence for complications of radiation, that is the point. That is going back 30 years back. You are quoting that. Do we have recent study for complications with the recent machines?
Yeah, Dr. Abraham.
Recent techniques.
Yes, we do have. We have level 1 evidence now from the TIME-C trial and the trial from Tata, where we are showing reduced complications, late complications with the use of IMRT. And of course, the image-guided brachytherapy. You can do image-guided wall brachytherapy also. So definitely the complications are less. They are less than, they are about 10 to 15%, and they are much lesser as compared to before. The significant grade 3, grade 4 complications are again much lesser as we had with the conventional techniques. So, so that is not, I mean, a reason basically for, once you have an involved pelvic lymph node, you have to realize that I don't think we would want to abandon the brachytherapy part. You cannot just give the external radiation for a patient.
Exactly. I was coming to that, because most patients receive brachy as well for.
Yeah. So any patient who has a positive lymph node, irrespective if it's a micrometastatic disease, a positive lymph node, because a number and the size of metastasis as far as now are not considered, as an indication whether to defer the chemoradiation or give. So chemoradiation has to be given, and at the same time, being a high risk factor, you even have to give brachytherapy. So it is always better to give brachytherapy in an intact uterus. The other thing is, if you're doing para-aortic lymph node sampling, it helps us because with a pelvic lymph node involvement, you can have up to 25% of para-aortic lymph node micrometastasis. So if your para-aortic lymph node sampling is showing metastasis, we can tailor our fields to do extended field concurrent chemoradiation with brachytherapy. So it is better to abandon the surgery, the hysterectomy.
Though I was playing the devil's advocate, I mean, I agree that the trend is to abandon surgery, but we should sample the node, only the enlarged nodes. Probably just do a sampling of the para-aortic. I mean, I wouldn't do a full lymphadenectomy if I'm abandoning surgery.
Absolutely, and especially if you can't remove the most ugly looking node, you go ahead with the rest of lymphadenectomy and all. I think that we would. Final word from Goodman, and then we move on to the last case.
Yes.
Yes, hold on, I'm being called for my surgery, but this is a fascinating discussion. And what I would say is the discussion reveals that there's no one answer, okay? All right, that's what I would say, is that you need to use your clinical judgment. So just to summarize, if you have the ability preoperatively to assess your patient by more advanced radiology techniques, that's great. If you have the ability to do a PET CT scan, you will probably identify positive nodes, and that may lead you to not operate in the first place, clearly, right? At the time of surgery, you're going to make a call about whether this is a small lesion that just happens to have nodes, just to the point of Dr. Abraham that, there are some times where it is sort of a small central lesion and it makes sense to do a radical hysterectomy. But there are other times where it's a big, bulky, stage 1B3 kind of situation, and you really want to give them chemo rads and you want to abandon the case. I just have two other points to make just for you to think about. One is whether you abandon or not, for your radiation oncologists, for their planning, to place clips where you see these positive nodes, right? Because they're going to change their radiation field and they'll be able to focus better if they know where this node is, right? Especially if you've removed it, right? Then you need to sterilize that area you made out of boost. And I defer to Dr. Kamal and everybody with that expertise to comment on that. And my final point is, this particular patient had a fixed node where you worried about having a vascular injury, right? The other piece of that information is that if this is not sterilized, if this disease cannot be sterilized, she has a risk of fistulizing and having a life-threatening fistula. We actually recently had a patient here who came in fistulized between her iliac and her colon from a recurrent cervical cancer and almost exsanguinated. All right, so when you're evaluating that area, if you have the opportunity to call vascular surgery to take an assessment, you may save your patient's life later by sterilizing that. If you can resect that node, all right, because it's possible that node could end up, invading that artery or vein and causing their death. So those are my comments.
Okay,
thank you for
excellent.
wonderful presentations. Yeah.
Thank you.
The last case, and
The last case will be presented by Dr. Mahbuba Khatun. She is from Rangpur Medical College. Rangpur Medical College, the northeast area of Bangladesh. I request Dr. Mahbuba Khatun to present your case. And the case is there is a long gap between external beam radiotherapy and the brachytherapy. And how must justify to complete the treatment?
Assalamu alaikum. Thank you, madam. Am I audible?
Yes, you are.
Yes, you are audible.
Mrs. Fatima, 49 years old lady, mother of 4 children, belonging to low socioeconomic condition, diagnosed as a case of carcinoma of cervix, stage 2B. Her histopathological report was squamous cell carcinoma, grade 2. Her treatment plan was concurrent chemo radiation, followed by intracavity brachytherapy. Patient received concurrent chemotherapy, 50 centigrade in 25 fraction, 5 days per week. She also received 5-cycle concurrent cisplatin, 40 milligram per meter square per weekly. she completed her treatment with and then she was examined weekly after taking proper history, per vaginal examination, and routine blood count. After completion of external beam radiotherapy, cervical growth was resolved. Then the patient immediately referred to Dhaka Medical College Hospital for brachytherapy within 7 days. Unfortunately, the patient was not visited to Dhaka Medical College Hospital as her symptom was improved. Due to financial circumstances, she decided not to complete her treatment and she lost her further follow-up. After 4 months, she again attended the outdoor department of Rangpur Medical College Hospital. She complained of irregular pervaginal bleeding for 2 weeks. Her general and abdominal examination was normal. On pelvic examination, a small 2 into 2 centimeter growth in the upper lip of vagina was seen. Both HMO3, no pelvic wall was involved. Ultrasonogram of lower abdomen, small hypoepic mass was found on the cervix. No lymphadenopathy, other organ was normal. Chest X-ray and other investigation was normal. Next, please. Patient was referred to oncology department of Rangpur Medical College Hospital for further better management. And that's all. Thank you. Thank you all.
Thank you, Dr. Mahabuba. Now I request Dr. Nusrat Hoque to present her evidence. Dr. Nusrat, please.
Assalamu alaikum. Can all hear me?
Yes.
Very good evening. This is our last presentation on evidence-based on the topic of ICRT after significant gap of EBRT. How much justified to complete the treatment? We all know about the standard treatment of cervical cancer, that is in early stage surgery is preferred. Pelvic concurrent chemoradiotherapy with intracavitary brachytherapy is preferred for stage 1B3 to 2A2 to 4A, and individualized combination systemic therapy for stage 4B. We have seen that our patient has missed the brachytherapy treatment after EBRT of 4 months. So he missed the treatment at the right time. Next slide. And we are finding the right way for her on the basis of evidence. Next slide. So after a gap of 4 months, can we avoid the brachytherapy? Next. Here is a paper published on Gynecologic Oncology by Johannes Karlsson et al. Differences in outcome for cervical cancer patient treated with or without brachytherapy shows that, next slide. Brachytherapy is a very important tool to achieve the dose to the peripheral and central part of the tumor, as well as primary tumor remission rate, recurrence rate, and all types of survival is improved in the brachytherapy group. Next slide.
Nusrat, wait, please. Nusrat.
Madam, I can hear.
Unmute. Yes, Nusrat, proceed.
In this slide, a paper published in 2020 in Astro Clinical Practice Guidelines showed that, next slide, brachytherapy still remains an essential part of curative treatment of intact cervical cancer. And I want to mention that the standard modality of SBRT and IMRT boosts have not been demonstrated to be non-inferior comparing to brachytherapy. And this higher technique has increased risk of local recurrences and toxicity. Next. So brachytherapy is very important for this patient. Now, is there any role of surgery after radiotherapy? There is a paper published in Annals of Surgical Oncology by Eliazria et al. Results of hysterectomy in patient with bulky residual disease after end of chemoradiotherapy shows a very disappointing result that there was surgery does not seem to improve the survival of the patient. Next. There is a paper by Shahana Parveen et al. Published in Journal of Global Oncology. Next slide. 2019. It includes 40 patients and the result was surgery is a viable treatment option for patient with residual cervical cancer after radiation. And radical hysterectomy after radiation is more morbid, but it has a better tumor control than extrafacial hysterectomy. Next slide, please. Next. 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 There is a paper published in Astro Clinical Practice Guideline in 2020. Next. Next slide, please. Despite high rate of local control, a small percentage of cancer do not respond well to chemoradiotherapy, and these patients have residual disease. So we can wait 8 to 12 weeks, and after 8 to 12 weeks, if the persistent of disease remain, then we will confirm by biopsy, and there may be a role for salvage hysterectomy or exenteration if feasible to improve the local control and survival with the risk of significant morbidity. Next. For this patient, any role of adjuvant chemotherapy? Next slide. According to the Astro guideline, still additional adjuvant chemotherapy is under study and is not recommended at this time. Next slide. For our patient, any impact of treatment interruptions? Next. There is a paper published by Srichai Krushan et al. On the treatment interruption shows that the 3-year overall survival of the uninterrupted group was significantly better than the interrupted group. So this factor is important to maintain the total treatment interruption. Next slide. Next slide. For our patient, any impact of total treatment time? Next. This is 2 paper. Please show the next slide. By Lucas Varstham, and the next paper is the next slide. Shin-Min Lin et al. The prognostic impact of oral treatment time on the cervical cancer. It reveals that it is very important to maintain 8 weeks, that is 56 days, to completion of the whole concurrent chemoradiotherapy with brachytherapy is very important for our patient overall survival, disease-free survival, and overall treatment. Next slide. I am end of my talk. We have discussed on the basis of evidence to rescue our patient who have missed EBRT and a gap of 4 months. So we are finding a way to treat her, but being a responsible oncologist, we always encourage the right treatment at the right time. So my take-home message is, next slide. Patient counseling is very much important in treating cervical cancer, and every treatment modality like EBRT, brachytherapy, or chemotherapy is explained to the patient with significance. Total treatment time is very important, and brachytherapy should be preferably arranged at the same institution, including the EBRT. And if there is a gap or persistence of disease confirmed by biopsy as early as 8 to 12 weeks after therapy, there may be a role of salvage hysterectomy or exenteration with improved local control, but with significant morbidity. And finally, I want to say Multidisciplinary approach always brings better outcome in cancer management, although in the cervical cancer. Next slide. And thank you very much for patient sharing.
So thank you very much, Dr. Nusrat and Dr. Mahbuba, for excellent presentations. And thank you so much. Now come to the patient who has treatment interruptions for financial and personal reasons, and now has, I don't know whether you'll call it recurrent or residual disease. How would you manage her? Bhagya? I can see Bhagya is there. Is she there? Dr. Abraham?
Bhagya is there. Bhagya is there.
Yeah.
Okay.
So I think looking at the situation, if already the gap for the ideal time for the radiation therapy has already elapsed. So I think if all other parameters are normal, I think we will post her for surgery. So that's the thing. But then again, we can also keep in our mind about exenteration in case that's necessary. But again, we have to counsel everything to the patient and take her to take a call on what type of management she would also need. But
let's okay. So let's go to Dr. Bhavana and Dr. Kamal and understand what is the ideal time for treatment. Whether is she still a candidate for brachytherapy or no?
Kamal, or should I? So
These are real world situation. We do see such cases.
We do face, and this is because we do receive referrals from different states where patients often come late, maybe month and a half later by the time they land to us. See, overall treatment time is very important, and we know it has to be within 8 weeks. 7 to 8 weeks is the recommended overall treatment time. And it is estimated that there is 1% loss of local control with every passing day, every extra day beyond that. But having said that, I don't think that we should, just let go any opportunity of doing brachytherapy, because the amount of dose that you deliver with brachytherapy is 2.5 to 2.5 times, and that is the dose which is the tumoricidal dose. And the patient does have a maximum chance of recurrence within the first 2 years. So why would I subject a patient to surgery right now for a patient who has had an incomplete radiotherapy treatment? And given the image-based dose escalation techniques that we have, even if she has a 2 centimeter lesion, I would say after 6 months, I would still prefer to give a dose escalated brachytherapy, image guided, and I would reserve the salvage surgery maybe for a recurrence. This is an incompletely treated patient. So in a non-ideal situation, I would not leave any opportunity of doing brachytherapy as long as the patient is suitable.
Yeah, I have only one query. Do you think the dose of brachytherapy would be enough to cure this recurrence?
Yes, see, for dose, we can these days give dose escalation. The amount of dose that is required that the cervix receives or the gross tumor volume actually receives is to the tune of 150 gray, 200 gray. It is only the cervix with the disease that we aim at 95 gray these days, or maybe 90 gray, but the tumor actually receives a very large amount of dose. So if you can respect the OARs, you can easily give that dose. In fact, if the patient just has an intact cervix, we could do away with the normal brachytherapy doses also. Because the local tumor dose for a disease which is not macroscopic right now, that would be enough.
Good to hear that, Bhavana, because I've had cases wherein after 2-3 months, our radiation oncologists have been reluctant to give brachy. I think hearing what you're saying makes sense.
Yeah, exactly.
I mean, if you can give, if you don't mind giving brachy after 3-4 months or even 6 months, it makes sense. If you can control the disease, why not?
Why not?
You can avoid surgery.
Not giving patient a chance. We always have the option of.
When our oncologists, after say even after 6 to 8 weeks, they are allowed to deliver any brachy.
So the salvage hysterectomy is
also
posted after brachytherapy. Yes, if there is some residual remaining, then we go ahead with the surgery. Is that it?
So yeah.
But another thought is that you do surgery now and you sort of reserve the radiation for any subsequent recurrence. Better to do, with all their brachytherapy and interstitial radiation, give it later on in case there is a recurrence after that. Now, while the parameter is soft and you can get away with surgery, I think perhaps you might want to exercise that modality.
Now, I would disagree with that because you can never give that amount of that quality of brachytherapy in interstitial brachytherapy that you can give with an intracavity brachytherapy. So why are we leaving that opportunity? I know the evidence right now. We really do not have evidence in this regard, but I mean I would strongly argue for in favor of brachytherapy. That if we have the opportunity.
Just 1 minute. But Bhavana, obviously this tumor which has got so fast, or that there's residual disease, it has not responded very well to PDR. One would think that, don't you think that resistant clones?
Your voice is but I think there was no residual disease at the cervix initially. We are doing brachytherapy for post-external residual disease, which is extending up to parametrium also. And we're achieving good local controls. We have evidence from the EMBRACE, which has been published last week. So I do agree overall treatment time is important, but if the selected few patients are suitable for brachytherapy, why are we reserving, waiting for a recurrence where we'll be giving interstitial where the entire bowel is going to be there? We are not going to be able to deliver the higher doses. What's the point?
So, Bhavana, let me add here.
The final word from you, Dr. Kamal. Very interesting discussion.
The problem is that the discussion of surgery is after completion of radiotherapy.
Yes.
The salvage surgery is 3 months or 2 months after completion of ICRT and EBRT. But this patient is only received EBRT, which is nothing. As Bhavana is trying to emphasize, the majority contribution comes from brachy, which she didn't receive. And the chance of cure is with the brachytherapy. Only surgery may not be enough. So rather on the other way around with Dr. Sekhon, we can say that we should treat the patient and keep the patient if there is a recurrence for later on for a salvage surgery. That would be a more preferred option. And as Dr. Abraham was telling, yes, ideal world, we don't want to give, but as Bhavana was telling, things are changing, technologies are changing. So if there is any chance for this lady, it is with brachy, not with surgery at this moment. We keep the surgery for at the end of total treatment, that is EBRT, chemotherapy, and brachytherapy. We exhaust everything, then there is a residual or a recurrence, then only we go for salvage surgery. Thank you.
Okay.
But then that is not a recommended practice or a practice to be followed, that we can, delay the brachytherapy. As far as possible, we should not delay the brachytherapy. Only in certain situations where there's an inevitable delay, there we should, we can give brachytherapy after a longer duration.
Okay, so the message from Dr. Bhavana and Dr. Kamaluddin is that brachytherapy can be given even months after EBRT. There is no timeline, right? That you have to give it within 2-3 weeks of EBRT. You can give it later also, right? Am I right?
No, but we don't agree to that.
Recommendation, again, like we said.
Ideally, it should be given.
No, we are not talking about, so in case, if there is such a situation, the whole discussion was a patient who did not complete initial treatment in time, and after 4-5 months she comes back with some residual or
can I have a question, please?
Yes, ma'am.
She has got ABRT 4 months back, and Nusrat showed that after 2 or 3 months, if any lesion is found, that should be confirmed by histopathology. And my question, whether this patient needs any histopathological confirmation of that, the residual disease or recurrent disease before going for any treatment.
Yeah, maybe that can be done. Confirmation by biopsy can be done.
By biopsy. I think she should have some confirmation by biopsy of the lesion.
So the question is, which modality is in reserve? Is it brachytherapy?
But the question is not about biopsy, not biopsy. It's about giving radiation, not giving radiation.
Or not, yeah.
I don't know. What about in TMH? Are the radiation oncologists?
Yes. So our preferred is radiation is preferred, and what we do, we would send, if patient has not received brachytherapy, we would give brachytherapy, and if at the end of brachy also there is residual disease, then we do surgery. So that's protocol we follow.
And Dr. Shana, your comment on adjuvant surgery following radiation in advanced CS cervix. I think you have published that paper.
Yes.
Yes. So what was your experience in that?
In that case, the patient completed either they have received the external beam radiation, somebody received chemotherapy and external beam radiation, somebody received only that everything, chemotherapy, radiotherapy, and brachytherapy, and they have come to us for after 6 months, somebody have after 4 months, and like this. And among this, only the patients who have the only central recurrence, then there is no scope of the radiation oncologist colleague, they told that there is no chance of, in that cases, we did this surgery, in the case of only the central recurrence.
No, without recurrence also there is now sometimes a request from a radiation oncologist to do adjuvant hysterectomy also after radiation.
I don't think there is any evidence to suggest at the end of radiation just remove the uterus. I think there is enough evidence against this practice, so we should not do that.
Yes.
Absolutely. If you are going to do that, you have to prove that there is residual disease.
Yeah, yes. If there is residual disease.
No, there have been 2-3 occasions in which they have requested us that the cervix is not that dense anachia, we are not able to assess the cervix, or it was an interstitial lesion, endocervical growth. Those very skeptical about a recurrence. So I think maybe from the patient side or from the radiation oncologist, I have done 2-3 cases on their request, of course.
Yes. The same request we also get from our radiation oncologist colleague. There is brachytherapy cannot be given. There is cervix clasped with vagina, and there is no scope of brachytherapy. Please do the surgery.
Definitely, those cases, yes, there is a role. The other point is, I think you have to remember that you have to wait for at least 8 to 10 weeks before you make a decision.
I think 3 months you have to wait.
Yes.
Yes.
Can I make a comment?
8 weeks sufficient. 6 to 8 weeks sufficient.
No, I mean, radiation effects last if up to 3 months. It takes some time.
Yes, we also, wait 8 to 10 or a little more before we label it as, any residual disease.
And a little persistent discharge. So that's again another indication.
Yes. Bleeding discharge.
Even if it is after 3 months, we always prove that yes, there is residual.
Yes.
Yeah, to have biopsy.
Yeah. We are running out of time. Yeah.
Can I make a comment?
Yes, I think the last comment and then close this session.
I think Dr. Kamal would agree with me. As long as there is a uterus, we can always insert a tank, even if it is flushed. Dr. Kamal, would you agree with me? Yep. We do ultrasound guided brachytherapy, so that is not a reason that we take.
I mean, I cannot do, but somebody can do. I mean, that cannot be an excuse for putting the patient on surgery. That I totally agree with you.
Yes, sometimes we advise that we'll make the space and we'll help you. We please, sometimes we revert back to the patient, to our oncologist colleague. You please try for the brachytherapy. We will help you if you ask us.
This is possible. This is individualized, and what Bhavana is telling, as long there is uterus and a cervix, there must be a way to treat. Maybe I am not able to put the tandem, somebody else may do, somebody like you maybe help me to find it out. But as long as it is there, I mean, this cannot be an excuse of not doing a brachy and putting the patient for surgery. So Amita, I think we can close this session because we have a
absolutely, we will close this session, and I think the message is very clear. It has to be multidisciplinary approach. At the end, what you rightly mentioned, even radiation oncologists can take help of gynec colleagues to put vaginal brachytherapy. So with this, I think we'll close this session, and thank you so much all panelists and organizers for the opportunity and for selecting this very interesting concept of discussing real life scenario. Thank you so much.
Thank you so much. Thank you so much.
Thank you very much. Thank you, Dr. Amita ma'am, for your exclusive moderation of the session. Now our second session, and the moderator of this session is Dr. Rupinder Sekhon. I request Dr. Rupinder Sekhon ma'am to invite her panelist and start the tumor board.
tumor board এটি কেমন কথা শাহানা রাত 11টার সময় টিউমার বোর্ড
Dr. Kamal and Dr. Shahana
for inviting us for this session. We have to present has basically already been discussed. So I think we will show you what how we are managing our cases and controversy there is. The Amita, Bhagyalaxhmi, and of course Shahana and Kamal would be there as well, and definitely Dr. Goodman too. So I think first I invite Dr. Pratima Raj. She will be presenting the first case. She is doing her DNB, which is equivalent to an MCH in gynae oncology. She is a second year student. And Pratima, will you please start the case? Yeah, Pratima, you're there, no? Hello, can you hear me?
Hello.
Hello, yeah.
Can you hear me, ma'am?
Yeah, I can hear you, but I don't know if anybody else can.
Please proceed.
Okay. Good evening, respected senior faculty and attendees. I thank Dr. Rupinder Sekhon ma'am and Oncology Club Bangladesh for giving me an opportunity to present this case. She is a 36-year-old lady, para 1 living 1, presented with complaints of heavy and prolonged menstrual bleeding per vaginum since 3 months. Her obstetric history, para 1 living 1, full-time vaginal delivery, and she is not ligated. There's no significant history. Her past medical and surgical illness was nothing significant, and her family history was not significant. On examination, general condition status ECOG score 1, vitals were stable, bilateral breast examination were normal, and no palpable lymphadenopathy. Per abdominal examination, soft, no palpable mass. On per speculum vaginal examination, 3 x 3 cm proliferative growth involving anterior and posterior lips of cervix, uterus multiparous in size, bilateral parametrium soft, pouch of Douglas and rectal mucosa free.
So I would want to ask the panelists, in this sort of a situation, when the patient comes to you, do you do a cervical biopsy in the OPD itself?
Yes.
Or do you take the patient to a minor OT, or do you do an examination under anesthesia and then do a biopsy? How would you all want to do it? Ibrahim, Bhagya, Amita?
Yeah.
While examining the patient itself, if it's friable, I may get some tissue. Otherwise, I'll take her to the minor OT, which is in the outpatient clinic itself.
Okay. And would you give some local anesthesia, or do you just take a biopsy just like that?
No anesthesia. It's a friable. It will be very friable. Exophytic growth. It will be friable. There's no need to.
Yeah. So same is our practice. We also take a biopsy in the OPD.
No, but if it's a ballooned out, endocervical barrel-shaped growth, then what would you do?
Yeah,
occasionally if the please go ahead, Bhagya.
So occasionally if the patient is suppose has a very narrow introitus and is very occasional thing actually. Most of the time we'll be able to do it in the OPD only.
Yeah. So basically what we want to convey is that every cervix should be visualized. You can visualize the cervix and you can biopsy the cervix in the OPD. Most of the times, rarely you might have to take her elsewhere, but that decision you will take only if you have seen the cervix. So it is very, very important to not just rely on her history, like what Bhagya had said earlier, that you might think it's a DUB or AUB or a fibroid or a some kind of prolonged menstrual bleeding and nothing more than that. It is very important to see the cervix. Next.
Rupinder, if it's not an exophytic growth, you might have to do endocervical curette. Use an endocervical curette.
Yes, we have often done that, and sometimes if it is a postmenopausal lady and the cervical length is very small, you have to use that endocervical speculum which we get, and then try to take a biopsy if you can. But if you are really not able to do anything, and the patient is giving a clear-cut history of a postcoital bleed, then it is prudent to take the patient to the theater and give some kind of anesthesia and then take a biopsy. Okay, Pratima.
Cervical biopsy was done in the OPD.
So, okay, we've taken a biopsy. Now, what kind of investigations would you like to do? Since we are talking with our Bangladeshi friends, can I have Shahana? What in a primary healthcare setup, what kind of investigations would you do for such a patient?
Just a minute. Pardon? What is your question?
I said, my question is that in a primary healthcare setup,
yes,
you know, whether all the facilities are not available, what kind of investigation would you do for such a patient?
Yes, at least in primary setup, that means we have the Upazila health. Yeah.
Yeah, some. You want to do some blood workup, or you want to do some imaging?
Yes, yes.
What would you want to do?
Health complex, at least ultrasonography. Humaira Begum, please mute. Humaira Begum, please mute yourself. Humaira Begum. In primary setup, at least the Upazila Health Complex and also in district hospital, we have only the blood reports and also the ultrasonography, and also the medical college hospitals, we have the CT scan, and also the tertiary level, some medical college hospital, we have also the MRI and the other imaging facilities, everything is available.
Yeah, that's right. So, Ibrahim, when you were in CMC or even your current experience, what are the first investigations, first-time investigations that you conduct in such a patient?
Yeah, I mean, blood work of hemoglobin, creat, those sort of things. Chest X-ray, ECG. I would get. I have to decide, you know, assess her fitness for surgery, or you know, also assess the extent of the disease. In which case, I mean, I might ask for MRI.
Okay. So MRI would be your first investigation, or do you want to do an ultrasound first, or do you want to straight away do an MRI? How is it? And would the MRI include the upper abdomen as well?
There again, it's that sometimes, you know, because depending on the finances, the patients, I might, you know, individualize it. But yes, I might do for upper abdomen. I usually don't routinely do upper abdomen MRI. I would definitely do a pelvic MRI. For the upper abdomen, I might do a CT or a ultrasound.
Bhagya, what about you?
Yeah, because most of the patients, when they come, actually, they already have ultrasound with them. So then, so the next thing we would like to do is either a CT or MRI, and whichever date we get earlier. So that is how actually we decide most of the time. Because in a government setup, we don't know, sometimes the CT dates come early, sometimes the MRI dates come early. But if it is a small disease and we want to really see about the parametric involvement, we would always prefer MRI. But about the nodal status, I think if it's a little advanced or we are not sure about what would be the nodal disease, we would advise a CT.
Then Dr. Bhagyo, do you suggest both MRI and CT in this case?
Oh,
as the tumor is 3×3. Tumor is quite big, 3×3.
See, that will depend mainly on my clinical assessment, what I have seen. If I have a little doubt about the parametrial infiltration or about the bladder, if there is any doubt, then I'll first prefer a MRI to a CT, which will also tell us something about the nodal status as well. But if everything is clean, I need to know only about the nodal status, I will advise a CT abdomen.
Amita, what would you do?
Yeah, so two comments. One, I think we should think how treatment investigation will change your treatment. You know, if you do MRI for a lesion confined to cervix, and if MRI shows that patient is in, intermediate risk and she might require radiation, your investigations should help in decision making. So our policy is we do MRI pelvis with abdominal screening for clinically early stage lesions. While if it is advanced stage, anything which is not for upfront surgery, our preferred modality is CT, CECT, contrast CT. So that's how we triage our patients, because MRI is more expensive, time consuming, and not all that freely available. So that's the policy we follow. And we
I totally
routinely
agree. I
don't-
mean, if it's an advanced case, if I'm not going to operate, I just do the biopsy and send her to.
So the other point is, if I'm doing MRI and if that shows deep stromal invasion, if it shows a large tumor, then based on MRI finding, and if I think like already intermediate risk factors are there, then we don't send these patients, post these patients for surgery and send them for chemoradiation.
So none of you all would want to do a PET CT?
Not in early stage. We would do PET CT only if, generally our policy is if CT shows enlarged nodes in pelvis, then we would do PET CT to look for distant mets. As a routine, we don't do PET for all patients.
Yeah,
In
PET
advanced cases, yeah, there is.
Yeah, she's a 3 centimeter growth, no? It's a 3 to 3 centimeters, just borderline, just less than 4, or might even be 4, because the 3 into 3 centimeters is a clinical assessment actually. So would you not want to do a PET CT if it is available, to see whether there are any para-aortic nodes or something like that, because that definitely will decide if the parametrium is soft. You've decided the parametrium is soft on a clinical examination, but to decide whether you want to operate or no.
Yeah, so Dr. Rupinder, we did a study at Tata in early stage cervical cancer, this kind of lesions, stage 1 disease. And we found that PET doesn't have better sensitivity compared to CECT for early stage disease. And the reason was majority metastases in early stage are micromets. So PET often, is not able to pick up. So early stages, we do not do PET CT unless there is a specific indication.
Yeah, I don't think PET CT is cost effective.
Absolutely, I agree with that 100%. And it's so heartening to hear all of you all say that, because many patients and in many centers, just because PET is available, they will straight away, even with a small growth, go ahead and do a PET CT scan. Pratima, can we have the next slide, please? Pratima, where did you go off? Hello, Pratima, aren't you there? I think we've just lost her. Hello, Pratima.
Ma'am, she got disconnected.
Can you share, Shona?
Okay, I think. Yeah, I think she's disconnect again. Needs to just share the screen. Let me just give her a call. Just a minute.
Shona, can you share screen?
Ma'am, I haven't downloaded it. Noman Bhai has downloaded it, I guess.
Noman? Not this one. Other one, other case.
No, the other one. It's the other one. This is the second case.
Second case, the first one, Numan.
Yeah, the first one.
Next.
Yeah, next slide. No, I think the slide before this. Okay, yeah, no, that's fine. Next slide, please. Yeah, next slide. Okay, cervical biopsy was done and it was a moderately differentiated squamous cell carcinoma. Next, so a CT upper abdomen was done and that showed no abdomen, there were no upper abdominal metastasis, chest X-ray was normal. Next. Okay, that's the MRI. Next slide, please. Yeah, so the MRI showed that the uterine cervix, there was a lobulated lesion, 3.4 by 3.7 by 2.9 centimeters, involving complete cervical stroma, anterior and posterior lip, posteriorly abutting mesorectal fascia without any infiltration. Bilateral parametrum are normal. There are no enlarged lymph nodes seen. Okay, Bhavana, do you want to give radiation here, or do you want us to take up this case?
Ma'am, this patient has a deep stromal invasion, as I can see, complete cervical stroma. So she has one intermediate risk factor.
Yeah.
The upfront. So this, I think, would again require a careful assessment in a tumor board whether we can take this patient up for surgery, because any other risk factor warrants adjuvant treatment in this patient, which would again increase the toxicity.
Okay. So what about the surgeons? Amita,
can I,
what would
Dr. Rupinder, can I add something?
Yes, of course.
Yeah, this is a, actually, this is a case of 1B2 tumor. So, and the patient is quite young. She is only 36. So I think it is better to do surgery in this case, that is type 3 radical hysterectomy with bilateral pelvic lymphadenectomy. Because particularly in this case, surgery has certain advantages. We can accurately stage the disease, and we can accurately assess the risk factor in the cervix. That is, in MRI, it has been shown that complete cervical stroma is involved, but we don't know the status of LVSI. So, and the tumor is also less than 4 centimeter.
Yes.
So, if we look at the SEDLIS criteria, any 2 out of 3 should be present to say it as having intermediate risk factor. So, better to do surgery in this case. It's my opinion.
Okay. Next slide, please. So the patient underwent radical hysterectomy with bilateral salpingectomy with bilateral ovarian transposition. Since she's a young patient, and since we did not know what the histopathology would be, and we were not sure whether she would require any adjuvant treatment, which, if required, would mean radiation. So keeping that in mind, we did a bilateral ovarian transposition, and like a point which AK had brought out very beautifully, whenever we do a ovarian transposition, we always put clips over there. So they work as markers for the radiation oncologist to be able to mark out the field for radiotherapy so that the ovaries can be spared. And a bilateral pelvic lymphadenectomy was done on, sorry, next slide, please. So this is the specimen. You can see there's a small tumor there, and we've got plenty of the cuff of vagina. Next slide. The histopathology report said gross tumor size is 3.5 by 3.5. 3.5. And gross distance from the nearest margin was 1.5 centimeters. Next. This is a squamous cell carcinoma, moderately differentiated, and P16 expression is diffusely positive. Depth of stromal invasion is 13 millimeters of 25, bilateral paracervical soft tissue free, LVSI not identified, perineural invasion not identified. Santosh, are you there?
Santosh left.
Hello?
Santosh left.
Santosh left. Okay, so Amita, can you tell us, do you want to do any other IHC markers on this? Or is this
No
P16
additional IHC marker required here.
Yeah, exactly. So whenever we have a controversy, perhaps we might want to add to this. But over here, I think the P16 expression is perfect. And now what next?
That's very interesting, discrepancy between MRI and final histopathology. There it was almost complete involvement, and final only less than third of stroma involvement. So she actually is now low risk, and she doesn't require any additional treatment because tumor size is less than 4 centimeter, superficial stromal invasion, LVI negative, perineural invasion negative, lymph nodes I guess are negative. I'm not seeing them here. So she doesn't require any additional treatment. We keep her under observation.
I feel our radiologists also overcall the vaginal involvement and the parametrial involvement.
There was no para involvement, but
just
yeah, I
saying that,
mean, generally,
they
yes.
overcall any small stranding. They'll say that, and they don't put the gel into the vagina routinely.
Exactly, that's the huge problem. So any tumor, larger tumors especially, always they would report vaginal involvement. True. And that's why important to understand limitation of imaging.
I think that's basically because they don't put the dye in the vagina. So the vagina.
Yeah, jelly, not dye, jelly.
Yeah.
So at your place, they put some dye, Bhavana?
Ma'am, sometimes they will just put contrast or maybe ultrasound jelly, so that outlines the vaginal.
Yeah. So here at our center, yes, we use jelly, which is. Why this cursor is moving randomly?
Amita, can I ask you about your policy for intermediate risk factors? I know Kerker was not keen on radiating.
No, we very sincerely follow Sedley's criteria, and we give radiation to all intermediate risk. That was his own idea. So we follow in Sedley's criteria and we give.
Okay. But then what would be your adjuvant radiation rate in
So we very carefully select Bhagya cases. So our adjuvant radiation rate would be, I think, less than 25%, because we do intraoperative frozen, we do preoperative MRI. So we are highly selective nowadays, and our adjuvant rates are much low. Of course, as a result, our number of radicals have gone down. Otherwise also, because we are, I think every center is seeing fewer cases which are operable.
Yeah, I think when you are not so selective, your radiation level rate should be 30 to 40%. I don't know, Bhagya, are you doing more?
Adjuvant radiation, no? That's what you mean.
Yes,
even
around 40%.
Yes, even for us, when we do surgery for cervical cancer cases, we are very, very selective. Only if you think that absolutely the parameter is butter soft, regardless of what the MRI reporting is, only then do we actually take up the patient for surgery. So apart from the fact that if it is a large growth and very obviously involving the cervical lips completely, obviously there would definitely be complete stromal invasion, and then again we do not take the patient for surgery. And what Amita is saying, even our adjuvant treatment for I think somebody will have to mute. Next slide, please. Yeah, so this is basically a completion of the histopathology report. Pratima, will you read that out if you're on now? Pratima, will you read that out?
Cervical carcinoma, FIGO stage 1B2.
Yes. So all nodes were negative. Vaginal cuff, as it is, we saw, I think we've taken too much of the cuff, in fact, some 3 centimeters or something, a little aggressive surgery, but one need not take such a large cuff. Next slide. So yes, so basically this, So basically the idea was there are just 2 points to bring out in this presentation. One is that you have to be very careful and very choosy about taking your patients under the knife. Be very sure that the patient would most likely not require adjuvant treatment, because like it has been reiterated, just giving 2 modalities is definitely more morbid for the patient, and it doesn't solve anything at all. And also,
Dr. Rupinder, do you always do bilateral ovarian transposition when it is required, or is it enough to transpose one ovary? What do you think?
See, we always do a bilateral, unless of course the other ovary is looking unhealthy, or for some reason, some adhesions are there or whatever else is there. For a young patient, we always do a bilateral transposition.
Yeah, I think if you want to transpose, you should do bilateral.
Yeah, if you're leaving behind both ovaries, you should transpose both ovaries. Unless one ovary is being taken out for some reason. Yeah, I think if you're leaving behind both ovaries, both should be transposed.
It doesn't make sense to leave behind one, to transpose one and leave behind the other.
Yeah.
No,
think it makes any sense. This. Any other comments? Anybody, any one of you would want to make, the surgeon especially? Okay. One more thing I wanted to ask Bhavana. See, most of the CA cervix patients, they come to us, but I'm sure there would be some patients who come to you as well directly from the OPD. What is your policy on imaging?
Ma'am, actually we get referrals only through gynae department because we don't have a provision for registration. But nevertheless, our policy for imaging in early stages, an MRI of the pelvis and a CT of the chest and abdomen. That's what we get done routinely. And for advanced cases, if possible, we get a PET CT, but we have a long way. Logistics is an issue. But that's the standard policy that we follow.
In every case, do you suggest chest CT? Dr. Bhavana, right? In every case of CS cervix.
Stages, you can go away with the chest CT, but for all locally advanced cases, we are doing a chest, abdomen, and pelvis.
Yeah.
At our institute, the rates are not different for chest, abdomen, pelvis, and abdomen, pelvis. So we are taking the and doing a chest, abdomen, pelvis for all patients, especially the advanced. Locally
That's great.
Yeah, that's nice. We actually do just a chest X-ray. We don't really do a CT for CT chest.
So we also use chest X-ray. Previously, we were doing CT abdomen for early cases, MR pelvis, but nowadays we do screening with MR only. So we do MRI pelvis plus abdominal screening with MRI. And X-ray
The important
chest.
thing is the cost. Bhavana has managed to have the same cost for chest, abdomen, pelvis.
Yeah, the only problem is
luxury
you may end up picking up some not significant lymph node in the mediastinum and further investigations and sort of things. So
for endometrium, and we stopped doing that.
No. See, the problem with doing CT chest is that definitely you will pick up some nodes here and there. We are a country, in fact, the whole subcontinent is such. We are endemic for tuberculosis and also low grade chest infections. So some one odd nodes will be large here and there, and then you want to do an FNAC of that, and the whole process gets
yeah. So you end up there are few cases where you will pick up some
indeterminate nodules will be there.
I think over a period of time, ma'am, everybody we know which are the suspicious lymph nodes. There are other indicators of metastatic lymph nodes. Plus, there are other indicators of metastasis, meaning that cervix usually follows a chronological spread. It's from if there's a lymph node involvement in the para-aortic, definitely I would look at a high suspicion if there's a mediastinal lymph node in the lung.
But, see, that situation is different. If there is a large para-aortic node and all, one would definitely want to.
Yes. So 1 centimeter, 11 mm lymph node, mediastinal lymph node, no necrosis, nothing. We would just leave it as that. And so I agree with you that that could be sometimes an over investigation.
Yeah, especially for early stage cancers, where you don't expect mediastinal mets. I think that may be a little over investigating with the CT thorax, but just maybe.
Our policy is basically because of the luxury that we have.
No,
otherwise.
But see, for for us, where most of the patients have to pay, though we are a trust hospital, and the payment is much lesser than private setups. There, if the lesion is very small and very early, in fact, we do not even do a CT of the upper abdomen. We just do an ultrasound of the upper abdomen.
Ultrasound is also good. Yes.
I also agree with that.
I don't even beyond that because everything adds to the cost. I would much rather.
But sometimes the CT abdomen will show you something in the in the thorax. So that those are the occasions actually we do a CT thorax, because sometimes the CT abdomen may tell you that something in the thorax.
Right. So lower cuts, when you get abdomen, you make.
Yeah, quite right. And sometimes
especially, I think during COVID times.
Yeah, and yes, during COVID times we've even changed our practice, because sometimes getting a CT data and those things can be an issue. They need a PCR. So there are times when we've even done with an ultrasound from outside that the patient can get done. So I think basically in advanced disease we want to know whether there is hydronephrosis or there is any metastatic lesion in the liver or any massively enlarged para-aortic lymph nodes. But otherwise, for locally advanced it's CT scan, but we can definitely do away without a CT chest.
I think we are running away with the time.
Yes,
We'll
ma'am.
quickly move on to the
Second case or
second case is going to be presented by Priyanka Makkar. She is also our second year DNB Gynae Oncology resident. Priyanka, are you there? She was here for a short while back. Priyanka?
I'm here. Can you hear me?
Yes, a little louder. Come closer to your mic.
Okay, can you hear me?
Yes, yes. Now we can hear you. Yeah, Priyanka. Let's hear you.
Ma'am, good evening all. 47-year-old para-3 live-3 presented in the month of July 2018 with the complaints of irregular bleeding per vaginum since 3 months. On examination, she had a large growth around 7 to 5 centimeter involving the entire cervix. Bilateral parametrium were infiltrated and they were short of fatal pelvic wall. The pouch of Douglas and rectal mucosa were however free. The cervical biopsy was done and it was reported as moderately differentiated squamous cell carcinoma. Next slide, please. So an MRI pelvis was done. She had a cervical mass measuring around 5.1 into 6.5 into 5.2 centimeters, involving the full stromal thickness with extension till mid-uterine segment and upper third of the vagina. The lesion was extending to bilateral parametrium but was not reaching till the pelvic side walls. The fat planes with the posterior bladder wall were indistinct with possible muscle infiltration along the right posterior aspect. No rectal invasion was seen, but there was an enlarged necrotic left external iliac lymph node measuring around 2.4 into 1.2 centimeters. Next slide, please. So, there is a 47-year-old lady with a PS score of 0 with squamous cell carcinoma cervix, stage 3C1 radiologically. So, what are the treatment options?
Yeah. So I think straight away it's quite clear that she's a patient for radiation. Does anybody disagree? Anybody on the panel? Amita, Ibrahim, Bhagya, Bhavana?
I think there is no ambiguity there.
Dr. Rupinder, do you suggest?
Yeah, sorry.
Okay, please go ahead.
Go ahead, please go ahead.
My question is, do you suggest FNAC to confirm that this is a case of, to confirm or to exclude that this is a case of C2, 3C2? Do you want to suggest to do FNAC?
You tell me.
Or surgical staging of lymph nodes?
Would you want to do anything? Would you want to do anything beyond?
Okay, thank you. If facility, in my institute, there is facility of doing FNAC. So I like to do FNAC in this case, because if the paraotic lymph nodes are involved, then the chemoradiation, the field of chemoradiation will be changed. That is extended field radiotherapy.
Yes,
so I want to do FNAC.
So see, there's a controversy on this. You might want to do a PET CT after this and then confirm whether there's any paraotic lymph node. Our radiation oncologists, sometimes they do get an FNAC done if the paraotic lymph node size is not very large, to confirm, so that they can plan their radiation fields accordingly. But if it isn't enlarged or something, they sometimes do an extended field radiation in any case. Bhavana, what is the practice in your institute?
Yes, ma'am. So basically, we do not do FNAC unless a paraotic lymph node is enlarged and there is a radiological evidence to suggest that there is metastasis to the paraotic lymph nodes. So we treat with pelvic radiotherapy only for a 3C1. But there is evidence emerging, although it is still in the trial setting, that there may be some pointers towards involvement of the paraotic lymph nodes. And they are, if you have a lymph node at the common iliac, so going by the basic principles of radiation, you treat one echelon above. So then you can treat the lower paraotics. The data from EMBRACE again has shown that if you have more than 3 involved lymph nodes, the chances of paraotic metastasis are high. So there could be some role of extended field radiotherapy. So all this we are doing currently in the trial setting as a prophylactic extended field radiotherapy. Now, if on, and our preferred modality basically in these cases is a PET CT. So if there is a PET CT, then we go ahead with extended field radiotherapy. Getting an FNAC for a lymph node, which is about 11 to 12 mm, is actually very difficult in our setup.
And it doesn't really
No, it doesn't.
Yeah, it's always better to do a PET CT. And like what you have already said, if the common iliac is enlarged, then one would in any case be covering the para-aortics at least till the not more.
Yes,
right?
yes, definitely.
Yeah, next slide.
Next slide, please.
Yeah,
So the patient received concomitant chemoradiation followed by 3 sessions of ICRT. Treatment was completed in October 2018. Next slide, please.
Next slide.
So in March 2020, patient was on regular follow-up till then. So in March 2020, she again came with complaints of irregular bleeding per vaginum since 15 to 20 days. On examination, there was a large growth at the vault, around 6 into 5 centimeters. Bilateral parametrium were infiltrated. Right parametrium was abutting till the lateral pelvic wall, and left was just short of the lateral pelvic wall. However, the pouch of Douglas and the rectal mucosa were free. Next slide, please.
So, okay, how much was the, sorry, okay, you can just tell them, we did a PET MRI at this point in time.
Next.
Okay, you can describe the PET MRI.
Next slide, please.
No, just describe the PET MRI. Okay, yeah.
The uterine, yes, ma'am. The uterine cervix shows a heterogeneously enlarged lesion involving full stromal thickness of posterior lip bilaterally measuring around 3.2 into 6.1 into 3.6 centimeter. The mass extended till the lower uterine segment and the upper third of the vagina inferiorly. It also extended to bilateral parametrium, but were not reaching the pelvic side walls. Anteriorly, it is infiltrating the perivesical fascia. However, the urinary bladder and the rectum were free, and there were no regional lymph nodes which were enlarged.
Okay, so how would you proceed from here on, Ibrahim?
Yeah, I would make sure there's no spread anywhere in the upper abdomen or extra pelvis. And if it's in such a case, I would talk to her about anterior exentration in this particular patient.
So do you want to do a cystoscopy before that?
Oh yes. I mean, it doesn't show any, on the PET, but still yes. Cystoscopy.
Yeah. So regardless of what the imaging might be, one does need to do a cystoscopy as well as a sigmoidoscopy, I think.
But whatever it is, I would remove the bladder. I'm not going to spare the bladder, so I don't know.
Okay, Amita?
Yeah, so I think this kind of patient, the choice would be at this point, because it's almost reaching to the lateral pelvic wall, you have to assess her. If you think she's suitable for exenterative surgery at this point, otherwise maybe a couple of courses of neoadjuvant chemotherapy, and then reassesses her for surgery. But definitely in this case, there can't be conservative kind of radical hysterectomy alone, because para is almost to the lateral pelvic wall, and there is disease is going down in levator fascia is also involved. So it will be exentration only. No, we can't preserve her bladder.
And is there any role of palliative radiotherapy also in this setting?
I think very short disease-free interval and okay, sorry, Bhavana.
Yes, ma'am.
No, you can go.
Please carry on. I think you're absolutely right. Very short disease-free interval. I mean, a disease which has not been controlled with a radical dose of radiation, there is not going to be much effect of radiotherapy at such a short interval. Palliative radiotherapy only for pelvic symptom control can be administered, but I would definitely want a surgical assessment. I have a question in mind, ma'am. Like you talked about neoadjuvant chemotherapy. I mean, in our experience, a local failure seldom responds to chemotherapy, a post-radiation disease. I would just want to know what is everybody's experience.
I find most of the time the tumor grows.
Exactly. Yes. So so even I want to know, I mean, because people talk about it, but I would want to know the experience. Somehow we've not had a very good experience.
Yeah, so generally, yes, in radiation field, recurrences do not respond to chemotherapy very well. Having said that, we do get partial response, especially in this case, you have to assess if she's suitable for anterior exentration upfront on clinical assessment and on other parameters. We would do that. Otherwise, we may try a few courses of chemotherapy and then schedule her for surgery.
Bhavana, she's had full radiation. Would you give her more radiation?
No, we would not give her more radiation. She's not a candidate for re-radiation. Re-radiation we give if there is a potential for cure, and that too if the interval is long. The interval that we usually take is around 2 years. In a patient who's had a recurrence in such a short interval, the role of radiation is only limited to palliation of symptoms of bleeding or pelvic pain if it is not controlled with analgesics. That is all.
Kamal, what is your opinion?
So, Dr. Rupinder, first of all, I want to discuss with the patient whatever we are going to do, it is a palliative. That is the first message we want to give. Because in our region, people think that we do some magic by doing some chemo or surgery, we are going to cure her. So first thing I want to discuss that we can do something, but it is palliative, number one. Number two, well, as Amita said, we can try with chemos. Sometimes it may respond, it may not respond. We are not going to chase for many cycles, maximum 2 cycles, because if the surgeon say it may make their life easy, but of course there is no scope for radiation from my end.
Yeah, the only other drug I don't know is bevacizumab, whether we want to discuss at this point or just leave it.
Ma'am, for a local reference, I don't think.
The point is, see, I tend to agree with what Amita is saying. See, this is going to be a very mutilating surgery, if I can say that, and it's kind of a heroic palliative attempt. And if we still cannot get negative margins, that would be very sad. So basically, to get negative margins, I would definitely want to try out a couple of cycles of chemotherapy, so that when you get the whole specimen, at least the margins are negative. Remember, you are going to give the patient a permanent urinary bag, and you don't know for how long the patient is going to live.
But the only chance for cure is exenteration. The only chance for cure, 40% chance you are going to give her long-term survival. So if she's willing for surgery, I would go ahead with anterior exenteration. But if she's not willing for surgery, she may not want a bag. Then, of course, chemotherapy and bevacizumab is an option.
40% would be even with that.
No, I'm agreeing with you as to the anterior exenteration, but I'm saying that if you want to give her that 40% chance after anterior exenteration, the margins, it is worthwhile only if the margins are negative.
Yes.
So to achieve that, I think it is quite all right to give upfront chemotherapy 2 or 3 cycles and then go ahead.
Okay.
Okay, next slide.
And Rupinder, do you suggest
Sometimes we get the patients who are receiving them more chemotherapy, that is 5 or 6 cycles in case of the big growth. There is no scope of surgery, no scope of the exenteration. In that cases, we have seen that the patients are getting sometimes 5 or 6 cycles of chemotherapy. Is it advantageous, Bhavana?
Actually, you have a fair idea about the response if we are planning to shrink the disease to make it amenable for exenteration after about 2 to 3 cycles. But yes, even in our setup, there are patients who do end up receiving 5 to 6 cycles if the growth is not increasing.
Yes.
You consider it as maybe a growth restrained, a suboptimal response. But if the patient is symptomatically better and there is no aggravation, there are patients in our setup also who do end up receiving 5 to 6 cycles of chemotherapy.
Okay. So Priyanka,
Dr. Rupinder, do you suggest lead in India, in any region? Do you practice laterally extended?
I have no experience of layer at all. In
No,
fact, in our
I think no experience. In fact, a couple of weeks back, a guy had organized, and we all realized that we were not even convinced that we should, unless there is no level 1 evidence anyway, or not even level 2 evidence in favor
in
of layer.
India. You are not practicing.
No, in
No, we
India,
are not
only
practicing.
Adair practices. Only Adair, there is a surgeon. He's the only one who does layer, I think, in India.
Dr. Rajaram, who was in Kilpok, who is now in private, he does it.
Yeah, see, and also when they are talking in terms of layer, they're talking of different compartments completely.
Yeah.
They are not talking of the the kind of spread and the kind of route the metastasis takes, and we talk about it like that. No? They talk of central compartment and the lateral compartment.
The philosophy is totally different.
Yeah. Ontogenetic TNM on TNM
1140
classification.
here. It's 1140.
Yeah. Okay. Yeah, Shana, just give us 3 more minutes. Okay, Priyanka.
Was planned for chemotherapy and reassessment was done post 3 cycles. Patient received 3 cycles of paclitaxel and cisplatin till June 2020. Next slide, please. Next slide, please. So now the PET MRI showed that there was a lesion measuring 3.4 into 4.7 into 3.4 centimeter. It extended till the bilateral parametrium but did not reach up till the pelvic side walls, and it infiltrated the perivesical fascia. However, the urinary bladder and rectum were free.
So in the interest of time, we'll just continue. So we did plan an anterior exenteration.
Next,
Priyanka.
Next slide, please. So patient underwent anterior exenteration with an ileal conduit on 16th of June 2020. Next slide, please. This is the specimen.
So you can see, there's infiltration. There you can see, this looks so much looks like a post radiation uterus, what it would look like. Next. Next.
This was the...
No, the slide previous to this, please.
The histopathology report was, it was a moderately different.
No, the slide previous to this. Yes, yeah, now you can tell us the full histopathology.
It was a moderately differentiated squamous cell carcinoma, 3 into 3.5 into 2.5 centimeter in size. 1.4 centimeter of 1.5 centimeter of stromal invasion was present, with bilateral paracervical soft tissue and perivesical soft tissue invasion. Tumor was predominantly involved the anterior cervical wall and vagina. It extended upwards towards the isthmus and the endometrium, with infiltration of the inner half of the myometrium. Parametrium and vagina upper two-thirds were involved. Next slide, please. There was no invasion into the bladder muscularis propria seen. However, the vaginal margins, urethral margins, and the cut uretral margins were uninvolved by the invasive carcinoma. Elvisi and perineural invasion were not identified.
Next slide. So what would be your take on further treatment? Bhagya, do you want to give any additional treatment to this patient?
No. I don't think I would offer any other treatment.
Okay, Ibrahim, what about you?
And only supportive care and care of the conduit and all those things.
No, I wouldn't give her any further treatment.
Okay, Amita.
So whatever it's worth, I think at our place, if patient has recovered well from this exentative surgery, we would consider her for remaining 3 cycles, that magic number 6. So she has received 3 new cycles. We might give her additional 3 if she is fit to receive, and so that that chapter is closed for her.
Along with bevacizumab?
No, Bev will not be, because she's just post-op. So next post, we can't give 1 cycle, and then giving only for 2 doesn't make sense. So we will just give chemotherapy, provided she has recovered from this surgery and she's fit to take. I mean, but of course we can argue and discuss it's worth or not. We don't know. We don't know that.
She's going to take some time to recover. Plus, this infection, sepsis problems are going to be there. So I don't know. Chemos.
Because she seems to respond. I mean, her disease has responded to chemo. If you see pre and post, there was some decrease in size and all. So,
okay.
Yes.
I mean, there's no right answer. We don't know.
Right.
But,
okay.
Yeah. Next slide, Priyanka.
The patient received 3 cycles of chemotherapy post-surgery, and it was completed.
So we also follow the same norm of that magic number of 6, like you said, and of course no Bev was added, and all of her treatment I think finished in September 2020, and she's on regular follow-up. Next slide. Okay, so so basically this is what we encounter sometimes. Very difficult decisions to make, and in fact in her case we were still able to do some salvage surgery. There are some patients post radiation, large growth, it's absolutely a frozen pelvis. In such situations, Bhavana, what would you want to do?
Ma'am, in such cases, when the patient
completely frozen, you can barely palpate, you can barely introduce a finger or 2 in the vagina, and patient is absolutely miserable. There would be bilateral hydrourethral nephrosis and so on and so forth, and it's just at a loss, and the creatinine would be high. We cannot give them chemotherapy. What to do with such patients?
And then these patients are referred to the palliative care clinic. In fact, patients who have hydrouterine nephrosis and who are in uremia, we explain prognosis. We do not even advise them a PCM. So we basically give them analgesics. We manage them with non-interventional techniques, and we explain prognosis. Only supportive care is what we offer these patients.
Yeah, I agree with Bhavana. In fact, it's important to explain to the relatives if there are no treatment options, just doing PCN, it doesn't really help make their lives miserable. So we also don't generally offer PCN to these patients if there is no definitive treatment and if patient is for palliative care only.
No, that is true. What is the policy, Shahana, in Bangladesh for such patients?
Usually, we don't do the exenteration, and the colleague, the urologist colleague, and they are accustomed to this. Rarely we do. Some cases we have did the exenteration. Otherwise, the patients only they receives the adjuvant chemotherapy, either 5 or 6 cycle of chemotherapy, and like this, and then they ultimately the patients lost for follow-up in maximum cases.
I mean, one option is now that immunotherapy has come in, there seems to be some role for some of these
so maybe
checkpoint inhibitors.
Right. So we do PDL1 IHC, and if positive patient, very rare, of course, patient can be offered.
I think it's in future that's going to play a bigger role.
In that case, immuno should be done to know the status of MMR or MSI. If they're positive, then targeted therapy will work.
So PDL1 IHC is done, immunohistochemistry for PDL1, and if that's positive, then we can consider for checkpoint inhibitors. So there are studies ongoing on pembrolizumab in cervix.
Yeah, I think there is a hype also for the same
for cervical cancer, but anyway, so ultimately this is essentially a hopeless situation, and all we can do is offer palliation to such patients. I think we need to call it off now. We are, I think, looking at almost 11:30 even in our country, 16 to be exact. And thank you so very much for the opportunity, Dr. Shahana and Dr. Kamaluddin. It's been a pleasure participating in all your oncology club meets. I think the whole year, the whole COVID year, we've been doing all of this.
Yes.
Really, week after week
And
to do
we
this
all have
is
learned so
really
much more.
fantastic.
Yes,
Thank you, Dr.
yeah.
Shahana.
Thank you very
Thank
much.
you.
You did a wonderful job today. It is 11:45:50 here in Bangladesh. Yeah. Now we think we should have to conclude the session, and before that, Kamal bhai, sir is there.
Sir is there.
Sir, please.
Still waiting.
Sir is still there.
Sir is still there.
My God.
I request our sir, and before that, from the AGWA session, our either secretary or the president-elect, anyone, you please comment on this session and our program, please.
I think I'll let Amita do it.
No, secretary is the
Amita,
speaker
please.
for AGWA.
No, I think we'll let the president give it.
At last we could
I think
conclude. At last we could conclude. Thanks so much. Thank you all very much. We had a very long and interesting session today. We are very much indebted to all our foreign faculties. Complete names. I'm not really but to everybody, my practice thanks, and to the participants and the younger participants who has taken part in this sessions. I'm really happy that they are very interested. Now we are at least 220 participants this evening. And now it is coming up to 80. Thank you all very much once again, and goodbye, everybody. Bye-bye.
Thank you, sir. Thank you.
Thank you so much, everyone. good night and goodbye. And I think maybe
Thank you very much. Thank you very much.
I think overall it was an excellent idea to have a very practical problem-oriented discussion. And I hope audience found it useful. And thank you, Dr. Shahana, Dr. Kamaluddin, and Oncology Club for organizing this interesting session. Thank you so much.
Thanks, Amita. Thanks to all. And we are thankful to you people who are now the part of us, not anymore a foreign faculty. Now we treat you as a local faculty. And I think we should thank the juniors. They have done a brilliant job today. They have made the case presentation and the evidence-based presentation. That was a great thing. And as we said, we had been enjoying the session, but it is quite late. And best hats off goes to the participants who were there till now up to 12 o'clock. So as there, she will be continuing this thing. Don't worry. More invitation will be there. More program will be coming up. And thanks to everybody. Special thanks to Shahana on behalf of Oncology Club for taking the pain of organizing this. And thanks to all our local and foreign experts and the faculties. Thank you very much. Good night. And we wish you to stay safe. And because the COVID is rising in our region, so, and during COVID, our virtual academic program will be there. So good night.